focus on one surgery. So to try to pack as many surgeries as possible for this learning experience is being experimented, and it went on very well. So today's the patient has already been in, and I will request the Dr. Krishna Kumar or whoever is in the theater now to start the case presentations, and the faculty can give how the positioning is done, how the theater arrangement is there, where are the endoscopes placed. Each of those small things, details can be discussed. Even the induction, that can be shown, because the neuroanesthetist, we are fortunate to have a very experienced Dr. Akila, Dr. Satya and Dr. Shri. They are neuroanesthetists. They do nothing other than neuroanesthesia, and that is a very essential part of any microsurgery workshop. In fact, the entire thing rests on them. Neuroanesthesia is a specialty which at VHS we have been having for a very long time. We never had general anesthetists. We only had full-time dedicated neuroanesthetists, and that also was a trend setting, because it is not any other person who gives anesthesia but neuroanesthetist. Another specialty of Dr. Ramamurthi's unit is that our neurocritical care is also managed by these three anesthetists, Dr. Akila, Dr. Satya and Dr. Shri. Dr. Shri has joined us recently, and she has qualified from Shri Chitra, and she takes special attention to make sure that the neuro nurses are also trained periodically, and that is helping to improve the standards. To say about the theater arrangement, again you have dedicated neuro nurses inside the theater. I will not name all of them, but it is led by Saraswati sister, who is the in charge, and you have a lot of other people who are there. So can we start from the theater, please?
Monday sir, morning. Hello. So Pandey sir, I am audible?
Yes, yes, sir. You are audible.
Pandey sir?
Yes, Krishna, good morning.
Sir, I am handing over to mic to Dr. Sukumar. Here, MIS T-leaf is started, infusion has been started in OT3.
Yeah.
Morning everyone.
Good morning.
So today we are operating on a mid-age adult where patient has a predominant back pain with radiating pain to the right side, but both when compared to low backache and the radicular pain, it is predominant back pain in this patient. So focus on. Can you see the X-ray here? So when you see the X-ray, the last space, the L4, L5S1, we can see there is a collapse space. When there is on flexion extension, there is a listhesis and instability of last disc space. So don't get confused whether it is 4-5 or 5-1, but always see whether it is a last disc space. You can see on extension this everything opens up, and on flexion there is a listhesis, grade 1 listhesis with a collapsed disc space. So you also see some vacuum phenomenon in the disc space here. So it all denotes that disc is degenerated, and patient has instability, and because of that patient has severe low back pain. When you focus on MRI here, the axial cuts.
Sir, Dr. Rahul here. Hello. Sir, just a doubt on X-rays.
Yeah,
Can you focus the X-rays?
focus on X-ray.
Is the listhesis actually reducing on extension, sir? Because we could not make out due to
Yeah,
video quality.
it is reducing on extension. It is reducing on extension.
Okay.
Yeah. So he's basically degenerative facet disease. It's not a lytic listhesis. It's a degenerative case. When you see in the MRI,
Any AP view is there to rule out any degen schooling?
no, you can see the AP. Can you see the AP?
Ah, yes, yes, sir. Yeah. Yes, sir. Yes.
Yeah.
Clear.
So when you see the MRI here, see the MRI, there is a bilateral foraminal narrowing with facet disease, bilateral facet disease, left more than right. So left facet is hypertrophic, right facet is also degenerated, and there is more vertical orientation of the facets.
Yes, sir. Yes.
So here the
Trifoliate pattern is also seen.
yeah.
Yes, sir.
So patient has what you say predominant facet disease, degenerative disc disease. So only doing foraminal decompression will solve the radicular symptoms, but the back pain will persist. Here predominant back pain is because of the facet disease and instability. So plan is today to do a decompression endoscopic fusion, where we go endoscopically into the disc space of L4, L5H1, then remove the disc and prepare the end plates and insert a cage through the transforaminal route and put a percutaneous screws. So this will give us fusion, fixation, interbody fusion, and increasing in the height of the foramen, because we are putting a cage which is bigger than what the space is there. So definitely there is indirect decompression of the foramen, which causes the exiting foot decompression. That is the plan today. Already Dr. Gaurav started putting.
Can you show us the incision?
No, we are just putting the trajectories, the K wires for 4 pedicles now.
Oh, okay.
Then we'll start with the K end plate preparation. Give us some 10 minutes, so we'll our K wire insertion will be complete.
Okay.
Then we'll do the. I'll show. We'll be coming back soon.
Sure, sure, sure.
Now I'm moving to OT4, where we are going started an endoscopic assisted microvascular decompression. I will hand over to Dr. Professor Jaiswal.
Hello, good morning.
Good morning, sir.
Yeah. This patient is middle-aged male who presented with trigeminal feature suggestive of trigeminal neuralgia on right side.
Okay, sir.
And you can see here the MRI. Can you put the
Image.
MRI?
the images are not clear. We require some more focus. Slightly
See here,
more.
this is fifth floor of the normal side.
You can zoom more. Yes, sir. Jaiswal, sir. Yes, sir.
You can see here, this is fifth floor of the left side, this is fifth floor of the right side. This is deformed with the some vesicle loop here.
Yes, sir.
Okay?
Yes, sir.
So this corroborates with the clinical findings. And we have made the, we operate this patient in plan for endoscopic vascular decompression. The
Okay.
patient is in supine position and the head has turned to the opposite side.
Okay.
And
It is not fixed.
no fixation, no
It
fixation.
is just on the.
Yeah. No
Donut.
fixation and no navigation.
Okay. Okay.
So, Dr. Sresh is making the keyhole here.
Okay, sir.
So, we have made a incision and then export the bone. We are
Can you
toward
focus on the incision and surgical field, please?
We are making a hole over the estenion.
Okay,
We
sir.
try to identify the transverse sigmoid junction.
Okay, sir.
And till it is exposed, we will keep on making the drilling the bone. And
Okay.
once it is exposed, then we will make about 2.5 centimeter keyhole.
Q.
Okay,
Yes, sir. Sure, sir.
this is the plan.
Yes, sir.
Okay. So right now we are making the opening and
Okay.
trying to identify the transverse sigmoid junction.
Okay, sir.
Okay, thank you.
Okay, sir. Jaiswal, sir. Krishna Kumar, sir. Krishna Kumar, sir. Can you hear me? Krishna Kumar, sir.
Yes.
Dr. Rahul here.
Yes, Rahul.
Sir, just one doubt with Jaiswal, sir. Already you MBD is microscopic MBD is much more it's already established thing. What extra advantage you have in endoscopy compared to microscopic MBD?
The, actually, hello, are you able to hear me?
Yes, sir. Yes, sir. Clear.
You see, this procedure, the technique is exactly the same.
Okay.
The only added thing is here we are using endoscope instead of using microscope.
Yes, sir.
So all the advantages of endoscope, like extremely good visualization, panoramic view,
Yes, sir.
and this seeing all the structures. You can see this any vascular loop anterior to the nerve. All these things, these are the advantages. The other thing that you do not require any retractor in this procedure. Although some people do not use any retractor in the microscopic MVD also.
Yes, sir.
So and the opening is also smaller as compared to microscope. And we always try to preserve this superior petrosal vein, which many times you need to coagulate once you are doing microscopic procedure.
Okay, sir.
These are the reasons. Okay.
Rahul, there is a study, there is a case, so there's a meta-analysis of 9 studies done by a Korean team. They found out there are 3 things important in endoscopic surgery. What they felt is the hospital stay and the financial is better with endoscopic surgery. There is a significant amount of incidents where you cannot find an offending vessel in a microscopic surgery. Those are identified easily with the endoscopic surgery.
Okay.
So those surgeries which are started with microscope where they couldn't identify an offending loop, when they use an endoscope they find out the offending loop.
Okay.
So approximately 20% of 15 to 20% is the incidents what they say in a microscope where you can't find an offending vessel. With the endoscope, these incidents has come down significantly. Okay. Sometimes when you do in a microscope, you are not able to see what's behind the nerve. With the endoscope, that is also
Possible.
identified, and you can rectify the loop. Sometimes there will be multiple offenders. With microscope, you are seeing only one offender. With endoscope, it is possible you can identify multiple. It's like an thick and arachnoid or in a vein along with an artery. So all these pathologies can be easily identified in the endoscope where it is a magnified field and the field is clear compared to that of a microscope.
You change the angle scope, change it to angle scope once you
So
enter
0
inside.
degrees for
For the work.
for the endoscopic. If you're going for an epidermoid or any other lesion where you want to go anterior to the brainstem, that time you may refer an angle endoscope, but otherwise 0 degree endoscope will do
That
for this kind of cases.
Okay. Okay, sir.
Just for your information,
Yes.
if you have only 0-degree endoscope, if you can manipulate it, you can use it just like a 30-degree also.
Okay.
It depends how you are manipulating the endoscope.
So the craniotome itself is very small, no? So
Yeah,
you can
yeah.
manipulate within that.
The manipulation means usually in the keyhole surgery, the endoscope sits at the 12 o'clock position, and working space is in the lower half of the circle. And but if you use endoscope in the 6 o'clock position, then it becomes 30-degree endoscope. So by this way, you can manipulate and make your endoscope 30-degree. 30-degree is nothing but visualizing the anterior upper part.
Okay. Yes.
Only disadvantage with endoscopy, if there is a bleed. Every time we are forced to remove it, clean it, put it back into it.
Right. Fox.
But recently I heard they are bringing a endoscope with a brush attached to it, which is supposed to automatically clean, which I am not sure, I have not seen, but my ENT colleague, Professor Mohan Kameshwaran, said he is going to buy it. So that is the only disadvantage with the endoscope. That is tackled
microscope because it's a direct machine. Yes, sir. Thank you, sir. Just to add this, actually, what happens, this is a 11th disadvantage, but once you learn it, this problem can also be eliminated. The other thing that because the assistant hold it and you in between the procedure you keep on irrigating it. Okay. The other
That the systems, the microscope cleaning system is available everywhere. It makes the endoscope very bulky because the more instrument you put, the more
Heavier.
there will be loss of your freedom of movement. So it becomes bulky, and again at the same time, when there is bleeding, you have to switch the on and you have to clean it. So with that time, you can just put saline and it gets clean away. So I don't find any advantage. We have in our OT, I have never used it, and I think it makes your surgery more comfortable. More problematical.
I think it's the assistant which is more important.
Yes, I completely agree.
Always.
Assistance is very important. Like that's why we brought our resident here at the stage. He's helping me. I'm thankful to him. So you have to when you are resident.
Can you show us the instruments, sir?
You only require a small dissector, pencil dissector.
The endoscopic part.
Yeah. I will show you. The other thing, a micro seizure and a fine bayonet person. That's all. Only 3 instruments are required in this procedure. You don't require any other instrument. I request Dr. Krishna to just tell you about his cases of endoscopic microvascular decompression he has done. What problem did he face? How could he do it?
The initial for a beginner, it will be time consuming. See, when you start, the procedure takes at least 2 to 3 hours for the endovascular decompression. As you progress, the time duration comes down. That is the learning curve is the only difficult part in endoscopic assisted microvascular decompression. Once if you have done enough cases in a through microscope, that gives a confidence to do to the endoscope. Only thing is you have to get trained with the endoscope,
The perception.
the angulation, the vision, the magnification, everything changes with endoscope compared to the microscope. So it will take some
When
time.
to zoom in, when to zoom out.
No, see, with endoscope, the first thing is don't zoom.
You take
You first,
zoom
really
nearby.
as a beginner, try to do without zooming. Get accustomed to it. Then, when you reach the critical point, as of where required, then you zoom in and zoom out.
Okay.
So it's not necessary. You should zoom in whenever you go there. Okay. So when you zoom in, what happens is the field gets narrowed, and you're bringing the instruments from outside. That makes that will be a problem. And one more thing is you need a good trained assistant, as sir said. Yes, you have to train your assistant first for doing any endoscopic assistant procedure. It's not there. It's not the case with the microscope.
Can you show us the craniotomy size once it's over?
It's been done. Once it's done, we'll show you.
The incision is straight incision, small straight incision, right?
It is straight incision.
Straight incision.
Yeah.
The incision is almost the size of the pinna, not bigger than pinna. In
Okay,
endoscopic
okay.
assisted surgery.
Okay.
Some people make horizontal incision also.
Okay, sir.
But
Horizontal.
Yeah. I have seen many people make horizontal incision also. Yeah. But some people make a
What is
small-
the benefit of making a horizontal incision?
They say that healing is good.
Oh,
Some people make a reverse hockey shaped incision also, small. So there are different type, but usually I think in India everybody makes some lazy ass or straight incision.
The early years, if you know, quite significant decades ago, all the incision for acoustic or positive for all horizontal only. Subsequently only they came paramedian, lateral, vertical, all those things. The earliest stage, if you see the history, all horizontal extending from one pinna to another pinna, and craniotomy done on one side.
AV team?
Rahul, just wait. We are still about to start the endofusion. Once it starts, we'll come online. Okay, just wait for it.
We can go to other theatre, but I think acromegaly is.
Acromegaly is not yet started. It's going to. We have just shifted the patient. We are going to infuse. Okay.
Can we have the scan discussion of the?
So after some time. Once it infused, we'll start.
Okay.
So we thought do more epilepsy में और कुछ करेंगे करके then I came to Cleveland.
Hello, Sukma sir.
Sukma sir, hello. Hello, Sukma sir.
Yes, yes, Rahul. Now they are placing the left S1K wire now. Okay.
Okay. So
Using the for the
can you briefly tell us the points? How does the percutaneous groove?
Good morning, everyone.
Morning, sir.
Yeah, so what I have done here is, if you can focus here on the patient's body. God's peace. I have marked lateral pedicle line, sir. Lateral,
Yes.
I think the lines will be not visible because I have started quite a time back. So lateral pedicle line I mark and inferior pedicular line I mark. So our entry point is just above it and medial to it. So the idea is not to cross the medial pedicular line.
Yeah, understand. You have to start from supralateral aspect.
Supralateral aspect, yes, sir.
Yeah. Okay, sir.
So
and at any point of time, you should not cross the medial pedicular line.
medial pedicular line, yes, sir. Once you are through pedicle and you are into the body, then you can cross it, sir.
You can check on lateral.
Yes.
Yes. Okay. So 3 KYS has been done. You are putting the
Last one, sir. Yes.
last one. Okay.
You can see the image in the CM. Just hitting.
Just can you give us a tip how to identify the pedicle, especially the sloping areas like L5 and S1? How to get that CM image in AP?
You have to put your CM in a lordotic angle, sir. Here L5S1 I put 20-degree lordosis angle so that my pedicle is completely oval.
Okay.
And another thing, medial lateralization, you land on TP and from there you just walk on the TP to get the facet lamina junction. And on the laminar junction of facet.
Now is the CM in position? In an angle?
There I am the lateral pedicular line, sir.
Okay.
I am not able to make it.
Yeah. Now I could see that. Okay, sure. I could see the AP view now.
Patient is little obese, so
Okay.
lateral viewing is little bit difficult.
Okay.
So I'll try to medialize here. However, I will try to medialize. But iliac crest, you can see the shaft of Jamshidi is being obstructed by the iliac crest.
Oh, okay. So you have to go little medial to that iliac crest, right?
if you're feeling hitting the iliac
Yes,
crest.
sir. Just now you must have seen I have.
Yeah, you adjusted it.
Adjusted.
Oh.
Now I will see where I am in the lateral.
Okay.
If I am in the posterior third of the pedicle or just entering the pedicle, I will be okay.
Okay, fine.
So idea is to parallel the upper end plate, whichever pedicle you are putting, you have to parallel
the end plates.
So I think here I am okay, sir.
Yeah, you are entering the body, I think now. The aim is to get the bicortical purchase at S1.
Yes, sir, bicortical. For L5 I have put K-wires in such a way that, yeah, tricortical I am going for L5 because it is a little porotic here.
Oh, okay, fine.
For L5 pedicle I have taken 10 degrees lordosis, sir. For S1 I have taken 20 degrees.
Okay.
Some time, let them finish the K-wire. Once the endofusion starts, it will come on online. Okay?
Sure. A simple process of identifying the pedicle on a C-arm can be a lot of issues, and the main issues normally is that the quality of your C-arm and the quality of your C-arm technician has to be monitored by you. So you will be struggling and saying that I can't see this, I can't see it. But if you take the help, for example, our OT technician is Mahesh. Even in Apollo I have specific people who are there and who probably help me to see the pedicle better. Obviously with navigation you can become even more precise, and I think the future is that the freehand technique will just get obsolete, because I have seen either you have radiographic direct visualization, there's a lot of radiation. Research into this, if you read between the lines, the freehand technique even in the best of hands has got sometimes as high as 23 to 24% misplaced screws. So now the practice, whether it is institutional or whether it is in the private corporate sector, actually puts a lot of pressure on you, especially in the private sector where revision surgery will cost the patient somewhere around 5.5 to 6 lakhs, and you are answerable there. That is why if you notice, the trend all over the world has been towards guided screws, because once you have breached the pedicle, once you have gone anterior, especially in dorsal, so what as a rule you must have very good OT technicians, and this is very well amplified in a textbook of neurosurgery by Laligam Shekhar, where he talks about his theatre setup. So you should, all of you young people should read these books, so that a master surgeon says that if you notice lapses on the part of your theatre personnel, change them. That means the error margins are there. That means if he is not able to do it properly, you will waste a lot of time. And I am sure Dr. Selvath Pandyan will agree with me that a lot goes through that. You should not have any variability in your theatre personnel, your assisting nurse, and even yourself. You should not accept, this is a little medially praised, because patients have been known to commit suicide because of intractable radicular pain post your misplaced screw.
Yeah, I mean, it's a blessing to have dedicated people to operate these systems. Hope you guys are lucky to have such a people.
So now at our institute, we have OAM now at CMC. So what we do is we screen the patient once with the frame on a spinous process, and then intraoperatively we plan the trajectory and the pedicle size, and then proceed with putting the screws, and all the instrument is navigatable. The only flaw to this is we have to use only the Medtronic system, which is currently it is not compatible with any other company. So, and we are just in the initial stages. Till now, so far, no breaches yet. Yeah, I think the future will be OAM based, probably OAM based. If the machine itself, if the cost and all comes down, it will be OAM based putting screw. Anyone can put screw. Even the residents can easily put screw. That's what I feel.
Actually, this entire thing, so there's a beautiful comment by Gardner. He was Benzel's chief at the Cleveland Clinic, and he said that the spine should not be anybody else's but the neurosurgeons. This is Gardner speaking, because if you notice, his concentration was there. That led to Benzel. That led to Benzel, and Benzel literally has tilted the thing because there are no margins. So the same person, that same neurosurgeon, should be able to take care of a dural tear, should be take care of a neural injury, should be able to take care of deformity. All these things should be taken care by that particular person. So this is Gardner's very emphatic statement that it is not something which you can do half do. You cannot not train yourself. So can I request this entire process of putting the K wires in, if you can show the way it is done to, I mean just to demonstrate to the youngsters, it would be a learning experience for them. Can I request that to be done?
I think now KOS are placed, so will you be doing the interbody fusion now after making the incision and with the KOS in place? Sukma sir? Krishna Kumar sir? So I have no endoscopic experience. I'm a very young neurosurgeon. I'm currently doing fellowship. So so that's what, to learn endoscopy looks like the future of spine surgery, I believe so, especially for discectomies. Otherwise, the rest of the thing, the dealing with intradural tumors, dealing with TLIF, all can be done through minimally invasive tubular retractors, which the Medtronic has. We can reduce the size of the incision. That's what I'm been learning now. I'm just converting myself from open to MIS, and slowly I will progress to convert from MIS to endoscopic. That's what is been planned for me. So that's what the younger generation also should like me should do. So if Sukuma sir is available, I need a query on this endoscopic. Sukuma sir?
Yeah, can you hear me?
Yes sir, yes sir, I can hear you sir.
Yeah, tell me.
So I just want to have a basic difference between the fully endoscopic system and the difference with that of UBE, biportal.
Yeah, see, the name suggests biportal, you are using 2 ports.
Okay.
In fully endoscopic, you are using only 1 port.
Okay sir.
And we are talking about minimal invasiveness or least invasiveness. The moment you are putting biportal, 2 ports, the space between the 2 ports need to be more
Okay.
to work. It's like laparoscopy. You need some space to work, right?
You need that triangulation.
Yeah, so when you triangulate and you want to create more space, you need to remove more tissue.
Okay.
So when you take a MRI after doing UBE and your uniportal, that is full endoscopy, the tissue removed is more in UBE.
Yes.
So because you need to have a more space, so the pressure of fluid should be more. So
Okay.
I talked to so many of my UBE friends where they say sometimes bleeding is too much that they need to use lot of pressure.
Okay.
Second thing, the saline seeps into the intramuscular plane, sometime causing lot of trouble post-op.
Okay.
So these are few things in UBE, but otherwise, except for the maximal invasiveness, the concept is same.
Okay.
You work
Any
under
extra
a-
benefit it has as compared to the single fully endoscopic system, sir? UB.
No, but for this disadvantages, only advantage is that when you are doing fusion, or inserting a cage, your the cage goes into the disc space and you are visualizing. So that's the only advantage. You are putting the cage under vision.
Okay.
In full endoscopic, what we are doing today, you are just putting the cage on a K-wire. So that's the only disadvantage where in fully endoscopy sometimes, especially in fusion.
Okay, sir.
Other than that, the full endoscopy has more advantages because the root retraction going below the thecal sac and working sometimes in UB become tedious.
Okay, sir.
Then the second advantage of UB is you want to work on the opposite side, like say you go over the top and you want to do opposite side discectomy. That is a little bit easy in UBE, difficult in full endoscopy.
Okay.
And the third advantage of UBE is the instrument used are all common instruments which use for open surgery.
So one port will be specifically for the working channel, and one port will be the endoscopic with the saline system.
Yes.
Okay.
So now we are Dr. Gaurav has placed the 4 K-wires here.
Yes, sir. See.
So now we'll go to the transform. Idu kudunga dilator. நான் எனக்கு இப்போ ஒரு டைலேட்டர் கொடுத்துருங்க இவங்களுக்கு ஒரு டைலேட்டர் இது மார்க் பண்றது ஸ்மால் டைலேட்டர் ஸோ நோ ஐ வில் டேக் ஜஸ்ட் ஏபி பென் கொடுங்கம்மா ஷூட் ஷூட் இல்லை இங்கே வரீங்களா இங்கே வந்தால் பெஸ்ட் இல்லை ஓகே இங்க வந்துடுங்க ஷூட் பண்ணுங்க ஷூட்
This is for the younger people. There was a time where there was no C-arm in our place. So we used to do all this with X-rays, multiple X-rays, including odontoid screws. With multiple X-rays, odontoid screws were placed with precision and we had that presented in Germany, telling them that this is what the resources were, and all the
இப்போ வந்து
fixations, dorsal fixations used to be anterolateral.
rotate பண்ணு.
So high transthoracic,
rotate.
mid dorsal transthoracic and thoracoabdominal. So large amount of experience was in fixing these patients doing these procedures. So the maximally invasive procedures, and we were able to achieve the result till the CIAM came. Morning, sir. Welcome. Professor Sundar has just come. Welcome, sir. He is one person who has always supported VHS and neurosurgery generally, this part of the thing. You would like to say something?
Shoot.
Hello, good morning to everybody. I am happy to associate with you all people. Thank you. If you go ahead, I will.
Lateral. Scale at
Can you show the CIAM images simultaneously? We just need to know where you are marking exactly.
simultaneously CIAM image பண்ணுவாங்க. Picture in picture CIAM image கொடுப்பாங்க. No, CIAM images. Yeah, CIAM. கனெக்ட் பண்ணலையா? இது அங்கே கனெக்ட் பண்ணிருந்தாங்கல்ல.
Can you show the CIAM
image காட்டுங்க.
image now?
சிஸ்டர் கொஞ்சம் பின்னாடி வாங்க, நீங்கள் இதே டச் பண்ணுவாங்க, ரெண்டு வச்சு சைடு வச்சு
So
டச் பண்ணுவாங்க.
the marker has been kept at the disc level, sir.
Yeah, so just at the
Yes.
disc space true AP I have taken. Now I am taking a lateral view
To confirm. Okay,
Shoot.
sir. Yes, sir.
சிஸ்டர் கொஞ்சம் இப்படி தூக்கி போடுங்க. இது ஷோட்
Okay.
ஷோட் 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 shoot 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 shoot. You have to be parallel to the end plates. Shoot.
Yes, sir.
இந்த பக்கம் வாங்க. ஷூட் பண்ணுங்க. ஷூட் ஷூட் shoot 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 shoot. You can see that is
Yes, sir.
plates are parallel now. I am marking here.
Yeah. Can you focus on the surgical field, please?
Yeah, I'll just marking this, just a marking. I'll just come to the surgical
So on
field.
AP you had marked at one spot,
Yeah.
and a lateral you have taken.
Yeah, so two AP and two lateral AP.
Is the point at the intersection of that lateral as well as AP, sir, as we do it in foramen,
No.
transforaminal?
No. So we just keep we go enter the lateral because here it is too lordotic.
Okay.
So the AP and lateral never meet here because
Okay.
it's too lordotic.
Okay, sir.
And there is no need to take that concept of meeting at one place.
Okay.
Now here our entry will be on the lateral line.
Okay.
So
Okay.
that's the idea.
Okay.
So
It will be on the lateral line, but
yeah, scale. Shoot. So now here you cannot see the marking because the plastic I am not able to show the marking. This is the lateral line.
Okay.
I am just measuring from the midline. Here I will take, because it's too lordotic, I will take around 10 centimeter here to enter the local needle.
How far it is from the K wire, sir?
10 centimeter from the midline.
From the midline, okay.
So because if you go too lateral, the cage becomes too vertical. Because we need to put the cage anteriorly here.
Yes, sir.
So being a cage, we want the cage to go more anterior rather than more posterior.
Yes, sir.
So that's why I'm entering medially.
I mean,
the concepts of transforaminal surgery and this one little bit differs because the normal for discectomy we go 12 or 13 centimeter.
Yeah,
but
for transforaminal.
Transforaminal. Here for the fusion we go little bit more medial so that our cage should be
can you show the CM image?
Shoot. Shoot. I just going there, you can see the touching the facet.
Yes.
Now we'll stop there and I'll take a lateral image here.
Okay.
The advantage of this technique is if at all there is a foraminal stenosis, we can drill the foramen, drill the superior facet and widen the foramen. So that's the advantage. Any pathology.
Superior facet non-articular side or articular side? In this
superior facet,
because in transforaminal you will get the non-articular surface.
Yeah, non-articular surface of superior articular facet.
Okay, fine.
Shoot. இந்த கேபிள்ஸ் நீங்கள் லேட்ரல் எடுக்கும்போது தூக்கி கொடுக்கணும். பிடிங்க தூக்கி பிடிங்கம்மா. அது பாருங்களா, எக்ஸ்ரேல பாருங்க, அது படுதில்ல. ஷூட். So you can see my needle is the trajectory is a little bit inferior.
Yes, sir.
So I'll correct the trajectory now. The depth is looks okay. I'll just correct the trajectory. Shoot. Shoot.
Okay.
You can see it has just gone below the facet.
Yes, sir.
And just go in and just stop at the disc level. Shoot. I'll stop there.
So it is in the lower foraminal zone.
Yeah. So I'll just take a AP now. AP le keela pottudunga. Shoot. You can see there I will be entering the disc there.
You are almost at the medial pedicular line.
Mid and medial border of mid and medial pedicular line.
Pedicular line.
Yeah.
Okay.
I'll be entering the disc there. I've entered the disc now.
Yes, sir.
Shoot. I've entered the disc.
Yes.
So I'll take lateral.
Okay.
Wire. Shoot.
You're in the disc.
So I'm there. So I can adjust little bit while going inside. I can adjust my this one. So now the concepts of transforaminal are different here.
Okay.
The fusion are different, so we need to go more anteriorly. Shoot. I gone more anteriorly here.
Yes.
And I'll just put a K-wire now I'm putting a K wire. Putting shoot. Can you see the K wire?
Yes, it is almost reaching the anterior border,
Yeah.
right?
So that's what we need here.
Okay.
So just now put a dilator now.
You're making a stab incision so that dilator will pass. Okay.
Now putting the dilator, shoot. Shoot. Shoot.
CM image, please.
CM cutting it. Shoot.
Yeah. Okay. So dilator should reach up till the medial pedicular line, right?
Yeah. No, it will shoot. AP. Here because the facet is very big, so
you have to drill some.
It might hinder
its entry.
So facet might hinder our entry.
Okay.
So maybe we might have to drill facet to enter the
yes,
foramen.
to the foramen. Yeah.
You can see here it's driving me to the upper foramen now because the facet.
Can you focus more on the CM, please?
Shoot.
On the CM, on the CM, please.
Shoot. Can you see?
Yes, sir. I think you are just under the pedicular, sir.
Yeah. No, just it's guiding me
towards upper foramen.
Upper foramen. So shoot. So what here I do is now because the facet is so big, it's not allowing me to go inside. Shoot.
Drill.
I'll drill there. I'll stop there and start drilling.
Okay, sir.
इधन शीत न रे बाबा जाने रहा So now I put a sheath there, shoot. So I'll just stop there and start drilling the facet and going into the foramen.
Okay. Can you show us the drill what you are using actually?
Yeah.
This. So you will be using the diamond drill, small diamond.
Yeah, you can use diamond, you can use the normal burrs. I'll just show you.
Okay.
இது வந்து டீ போட்டு இது இது வந்து இப்படி வரணும்னு சொல்கிறேன் இன்னும் போடுங்க இது என்ன எங்கே போயிடுச்சு ஃபுட் ஸ்டூல் இந்த பக்கம் வாங்க அது பின்னாடி எடுத்துக்கோங்க இந்த கால்லேருந்து எடுத்துக்கோங்க இழுத்து விடுங்க இது உள்ள தள்ளுங்க சுன் எடுத்து புஷ் 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 Right like that. It's a difficult case not for a beginner to see because it's not a straightforward case of endofusion.
Okay. Usually you have to drill some amount of SAP to enter into the...
A significant amount of SAP need to be drilled here.
Okay, okay.
Saline.
In normal cases, at least some part you have to drill.
No, normal cases there is no need to drill.
Okay.
Saline. Edra inna puja pannu tunke phone edukkirathu. Sister, in the drill இந்த பக்கம் வெச்சுக்கோங்க நீங்க இந்த ஒரு மாப் போடுங்க சிஸ்டருங்க. மாப் RF तेरे पास है ना? ನಿಮಗೆ ನನ್ನ ಶೋಲ್ಡರ್ಗೆ ಟಚ್ ಇದು ಆಗಕೂಡದು, ಕೀழே விழுந்துடும் இது. ஃபுட் பெடல் எனக்கு லெஃப்ட் சைடு வைங்க. ஷூட், சியாம் ஷூட்.
So what we are seeing is a hypertrophied facet.
So because of the hypertrophic facet, we need to little bit drill there. So I'll just, can you see the endoscopic image now?
Yeah, it is in PIP. Yeah.
So you can see there I have just landed there. We have to search for the landmarks now.
Okay.
I am on the right side. So 3 o'clock is cranial, 9 o'clock is caudal.
Understand.
So we need to search for the bony landmarks here. So as we were trying to enter, punch normal there pehle. As we were trying to enter there, bone was not allowing us to go inside.
Yes.
So here there are some handheld reamers also. If you want, you can just use handheld reamers to just ream the bone. So first I will try to see the landmarks here, try to understand the bony anatomy. I can feel the bone there, so I will just see what is that bone. Then I start drilling.
Okay.
You can see there's probably facet capsule fiber seen there.
Yes.
But we need to understand where is the lower border of the superior articular facet.
Okay.
So only then it is easy to drill. Otherwise you might go through transfacetal drilling and you might not have a free edge of the inferior free edge. So you need to have a inferior free edge. So I'll just go there. First remove this tissue.
Okay. All those tissues are on the facet. Yes.
On.
So that's the bipolar cautery. No?
Punch. Shoot. Shoot.
So that's it.
Hey, go no, I'm outside, no? Shoot. Punch. Punch. Once we get that bone then it is very easy to understand.
The anatomy, yes.
So anatomy, so just you can see, I'm just working below the facet capsule.
Capsule, yes.
So I'm just
Could
trying to remove this muscle and the fascia, so that we can go underneath the facet capsule. RF. So I'm just
There was a question from the audience that RF ablator that we use for bipolar, can it be, has it any cutting mode to cut the tissues?
Yeah, you have a cutting mode also, but the drawback is,
Yes.
if you use a cutting mode, the tip gets spoiled and we cannot use for the next case.
Okay,
So
okay.
this is meant
But
for
ideally meant for only one time use.
one
I think.
use, yeah, single
okay,
use. So here we have to use multiple times.
Sure.
It becomes difficult.
What is the setting like?
Setting is 20-20.
Okay.
Because we are on the left side, the 3 o'clock would be the tip of SAP. So we are just
Yes, sir.
punch.
So exiting route is protected from the outer sheet, by the outer sheet, right?
Yeah, still we have not gone till the exiting route here, because we are way away outside.
Rahul,
We are here
we are
extra
switching
foramen,
to
right?
OT4,
We're way
where
extra foramen
sir is
here.
done the craniotomy and
Once
we
we
are
go near the foramen, then we can
Okay, sir. Okay.
protect the exiting now.
Sir, we are switching over theaters.
Yeah, no
Yes.
problem.
Yeah, we'll come back to you.
Yeah. Hello,
Hello, sir.
are you able to hear me?
Yes, sir.
Yes, can you see the bony opening?
No, sir. Camera, can you focus on the craniotomy surgical side, please?
Yeah. Punch.
Yes, sir.
Are you able to see it?
Yes, sir. Yes, sir. Can you orient us, sir?
Yeah. Okay. Yeah. Actually, this is a camera, external camera view. So now, are you seeing the endoscopic view?
Yes, sir. Not the endoscopic view. We are seeing-
Okay.
Yes.
So just hold on.
Yeah, endoscopic view is in PIP.
शॉर्ट पण आहे so we're going little bit near now. Bill normal लगा दे रहे huh? Are you seeing the view now?
Yes, sir. We are seeing the endoscopic.
See, I want your dilate.
This is medial side.
One minute, sir.
This is medial side.
Then you can come out and play. You know anatomy.
Some audio issues are there. We are just sorting it out, sir. Just a second, sir.
See, here even in transforaminal also
Is it okay now?
It is not allowing.
No, sir. Just we are correcting the audio issues. Yes, sir. Yes, sir. You can proceed. Jaiswal, sir. Yes, sir.
Yeah. Just a minute. This is medial.
Okay, sir.
This is lateral.
Okay.
This is cranial.
Yes, sir.
This is caudal.
Yes, sir. Yeah.
This is a transverse sinus.
Yes, sir.
Here this is sigmoid sinus.
Okay, sir. Okay.
Okay, this
Fine.
is the bony opening,
Yes, sir. Yes, sir.
like my index finger.
Yes, sir. Yes, sir. Very small. Yes,
Not
sir.
very big,
Yes,
but
sir.
it's okay.
Yes, sir.
So now I will open dura like this. Here I will open the dura, a curd, make a slit here.
Okay.
Then I will open the cisterna magna from here, retract the cerebellum with my suction,
Sure.
and then after drain some CSF and then the proceed.
Sure,
After
sir.
the brain is opening legs, there is no tumor here. Okay.
Yes, sir.
Okay. So once I open inside, I will show you.
Sure, sir.
पकड़ हाँ ले आ जाओ इधर वो कहाँ पे आपका स्टूल वाइट बैलेंस हो गया
बाइबल ये है
Yes, sir.
For the youngsters, if this debate about a craniotomy or a cranectomy in the posterior fossa is a very important thing to do. And if you people have watched the video where Janetta says that he would rather prefer a cranectomy, and then he goes on to explain that he has lacerated the sinus. So now what I'm trying to tell you is somebody with as large volume as Janetta, Peter Janetta, says that he would rather do a cranectomy rather than a craniotomy. The amount of space which you get in a craniotomy or a cranectomy is comparable. But the incidence of, because even in this past week, I have done a microvascular decompression in a young lady where I did a cranectomy. And then I did a little elderly lady for a vestibular schwannoma. There I did a craniotomy and I did get into some bleeding with the sigmoid transverse sinus junction. So now this debate, would you, Dr. Jaiswal, like to say what is the practice in SGPGI and what is the practice in this thing? It is a cranectomy, and what is the practice in CMC Vellore? It is cranectomy or a craniotomy?
Actually, yeah.
Please go ahead, please go ahead.
Usually in keyhole surgeries, not in RMSO, we used to make a small mini craniotomy. But here many times I'll end up in making a craniotomy because the opening is very small. And moreover you have to find out first landmark transverse sigmoid junctions to make a burr hole at the sternum with a drill, and then level the drill bonio edges middle superiorly and laterally to find out where is the location of the this transverse sigmoid junction. Like my burr hole was here. See, if I have made the craniotomy, it had been like this. Yes. So I first found out here. So first I nibbled it till here, then transverse sigmoid junction I got. So the opening is now appropriate. Otherwise, I would have made the craniotomy, it would have been far behind. So because of this, I will end up in making craniotomy in a case of RMSO. Okay? Otherwise, in other places, I make craniotomy.
It's the same at our institute also. We just do the craniotomy. We don't do craniotomy.
So, so general trend there is now craniotomy. So what is the incidence of sinus injury in your center? Because remember that once you injure the thing, if you are lucky, it is a small thing, you get away. Otherwise you end up packing that thing with gel foam, and then you can cause a occlusion of the sinus with that, which is the reason why Janetta says that he would prefer a craniotomy. Dr. Selvapandian, because there in our practice at Apollo, it is a craniotomy, but both Dr. Selvapandian and me were actually trained mostly in cranectomy.
Yeah, I would plumb for craniotomy because the way I do it is I drill the superior and lateral portion so that you can protect the sinus, the rest of the bone. See, one of the, I still remember one patient who was a dancer when I was in Kerala, where we did the usual early days, so craniectomy, epidermoid, CP angle. She repeatedly kept coming back with, you know, various symptoms. I think it is because of the craniectomy. While with the craniotomy, all the pseudomeningoceles and all that seems to be much, much less. So I think even if the bone, remaining bone piece is small, I think there is some positive effect on the dura. You know, it sort of keeps it down. So I think, I mean, it depends on the way others do it, but I drill the superior and lateral part to delineate the sinus, which is safe. I don't think we have had disasters yet, rather. Sure.
So my take is in the elderly, very elderly people, where the dura is going to be thin and the dura is going to be adherent in the posterior fossa, there probably you can err on the side of a cranectomy. In a microvascular decompression, anyway, all these craniotomies and cranectomies have got that 1 rupee size dimension, because we do not make large craniotomies also. The fixation of that bone at the end of your 4 burr holes, I mean you make 4 holes no, to drill the thing, actually the bone is quite reduced, if you notice. So now that is why the American practice, where they get sued, is either to replace it with acrylic or titanium.
Oh, I want to show. Okay. Yeah.
Completely. And so this is a very debatable thing. So what we do at our center is, in case we do a cranectomy, and we have published this, and this is a very common usage actually, is to put bone chips in gel foam and pack it there. But the pseudo-meningocele and all, probably you can reduce by Goel stitch. I hope all the juniors, young people know Goel stitch, because in standard operative neurosurgery textbook, he published this as a technical note in neurosurgery. And it's called the Goel stitch. So you have dandy stitch, Cushing stitch and Goel stitch. And we should actually respect the fact that that goes a long way in preventing a pseudo-meningocele. It should be meticulously put, and no resident should not learn how to put it and how to take the Gallial stitch of Goel.
Sir, Pandey sir, Dr. Jaiswal is there to commencing the endoscopic assisted microscopic decompression, sir. He is online.
Yeah. Can you see I have opened the dura?
Yes, sir.
And now I am trying to open the cisterna magna to make the bone further.
So the endoscopic view is, I mean, it's freezed.
Are you getting the view?
No, the scope view is as frozen. We are not, it's static.
Are you able to see now?
No.
Oh, audio-visual problem hai. देखो भाई, bayonet. Can you give me a bayonet? Fine bayonet. Yeah. अंदर ना, dura के अंदर. That's all. That is okay. Okay, not comfortable? Pani, saline.
AV team, the visual is static.
दूसरा दीजिए.
Yeah.
अंदर one. Yeah.
Yes.
Give me one. Okay.
Jaiswal sir?
Yes.
You can orient us now.
Are you able to see now?
Yes, sir. So we are releasing the CSF.
Yeah. Just hold it. Fix it. Okay. No problem. Bayonet. Pani. Do you have a recurrent knife? Saline. इसको छोटा कर दीजिए, इतना छोटा. So I have opened the, do you have a detector? इसको बाहर ये रखते हैं ना. Are you able to see the?
No, sir. The image is static.
अरे कृष्णा जी देखो भाई क्या स्टैटिक हो गया है.
Yes, sir.
Are you able to see?
Again some glitch, technical glitch here.
That is
Stop explaining that, I think.
Bennett, is it okay now?
Yes, sir. Yes, sir.
So the brain was full. Have you seen now it is relaxed?
Yes, sir. Yes, sir. Yeah.
Are you see the relaxed brain now?
Yes, sir.
Up. Hold करना. No, it's okay now. Perfect. Okay, comfortable? No problem? No issue. You have to make your assistant very comfortable.
I know.
Don't it?
You have to hold the thing. Ramamurthi was saying, 6 to 8 hours I have to hold it like this. No movement allowed, because he is operating with his lamp. And those years. We call that as human legs.
You have done very good turn.
Again, the image is not smooth.
Yeah, I think this will be good.
The streaming is not smooth. AV team.
No, slow. Don't turn.
Yes, sir.
Can you hold? No problem? No issue.
Jaiswal, sir?
Yes.
Yes, sir.
Are you able to do 7 bed complex now?
Yes, sir.
I think this is lower KNR.
Okay. No need to disturb that arachnoid, right?
No, I open some more CSF.
Thank you.
Do you have bipolar? One touch है? One touch रखना इस रखिए one touch. ठीक है? हाँ?
It's a beautiful demonstration of anatomy, and the theme of this workshop is very, very well reflected here. Retractorless endoscopic neurosurgery. Because if you notice, this dynamic retraction is all what you require in most of neurosurgery. Just putting a retractor and leaving them for hours creates a huge amount of problems. So this work, again, Spetzler started this revolution, and obviously the technical advances made by Pernesky, Joe, so many people. I would encourage all of you to utilize these learning mentors and make them your personal mentors.
Okay.
If you read a book by Pernesky separately, he becomes your teacher, he becomes your guru, he becomes your mentor. When it is possible for you to speak to them, Pernesky is no more. But this is dedicated to people like Pernesky, where they were able to Taka Fujikori, you must remember, he's a giant. Again, another neurosurgeon, Japanese neurosurgeon, who took neurosurgery to a different, he operates in different places in Germany, in Japan. Again, Taka also reduced retraction, talked only about reducing retraction. And that help is possible by scopes, endoscopes. Major way of reducing retraction is, in microscope you need that light to go in. For that you need a wide opening. Here if you take the light source directly to the place, you really can do a keyhole properly. Professor Jaiswal, are you using any specific, what are the instruments which you are using which will allow this? Have you brought your instruments so that you can also reflect on that and let these young people know that?
Sir, is that the vessel that is causing the loop, sir, in the cauterizing?
Sorry, let me first expose it, then I will speak.
The key, I will allow him to concentrate on his surgery. The key here is arachnoid has to be cut. So remember that you gently keep on going in the middle of the arachnoid, keep on separating the arachnoid, because that sharp and wet dissection is mandatory. Be very, very careful because these are physiological surgeries. It's not tumor surgery.
Are you able to see these lower cranial nerves here?
Yes, we can.
This is 7th cell complex. This is petrogel vein. So now I will make an opening here in this arachnoid and find out the 5th nerve, okay?
The key here is don't see the lower cranial nerves. So leave the arachnoid perhaps there intact.
No issue?
That's a protection. But where the angle, so even your cranectomy, this is very, very given in Kano's book. Have you seen Professor Kano's book on microvascular decompression? It's worth seeing. Please get that. There is a book by Majid Sami which talks about the various nerve entrapments. It's on cranial nerves. Majid Sami. Because you must remember that he started his neurosurgery from peripheral nerve surgery. From peripheral nerve surgery he moved on to cranial surgery. So obviously the magnification, the anastomosis thing he brought from one specialty.
No, he's comfortable.
Might change my position.
Okay. No, just comfortable,
it's okay.
Actually, we have different chair.
I know.
I
actually know that I have to be comfortable to show him. Otherwise, I know.
यहाँ थोड़ा सा bleeding है देखते हो, ये dual S bleeding है. तो telephone दे दीजिए. Can you give me telephone? Some more. Yeah, you have a plate right now. This simple needle. Yeah.
Sorry for
interruption. No. Yeah, do you have a needle?
Hello. Sorry for interruption, sir. Sir, I have a question. How to manage the sinus injuries during the craniotomy or cranectomies?
Just put a gel foam and pray to God. Have some patience. Spend some time.
If it is dural legs, sir.
Sorry?
If it is a dural legs.
Just press it. Just press it for some time. Have patience, it will subside. Gel foam is the best. Can you hold it? No issue? No problem? By pani. Yeah, I will do it.
Sir, should we try to insert a part of gel foam inside the tear?
Sorry?
Should we try to insert a part of gel foam inside the tear?
Where is the tear?
In the sinus, sir.
Yeah, you can pull it. You can insert it, yes.
Yeah, remember that caution is you put a sharp dry piece and make sure that you don't occlude the sinus. You just put it little bit inside, the inner part will swell and it will block it like a seal. You must know how to do that very well. Otherwise, you will get into a big problem with that. So do not panic. Otherwise, do the conventional way which we have all been taught, is to play a gel foam on top of that. Flow seal is remarkable, but remember it adds on to the cost nearly 30,000. How much is flow seal now? Yeah, but remember 18,000 in CMC Vellore means in Apollo they will add on another surcharge. Okay, it's 8,000. So here, in especially in my other practice, the hospital puts us a charge, you know. So it eventually becomes, no, it's more than that. So it becomes, you know, they charge for their establishment. You can see whenever it goes inside, but superficially you can use.
This is a 7th cell complex. This is a petrosal vein. You can see here this is a fifth nerve. A loop is compressing over the fifth nerve is deformed. Are you able to see it?
Yes, we are able to see, and there is an arachnoid over that which is holding it.
I will separate it. Okay, are you comfortable? Yes. No issue. Dissector, please.
Do you use any stitch or later to keep it away, or it is only shredded Teflon?
Yes. Some little bit. Okay.
Earlier the retraction is, you should retract it from superior inferiorly. This is all taught. You should not retract it from medially to laterally, the cerebellum. In fact, there should not be retraction. That's what is possible here. So this is a beautiful demonstration of physiological surgery. All surgery should be physiological, that you should not cause any trauma by retraction.
So, question to Pandey sir, like earlier we used to put this pericranium instead of pre-Teflon era. We used to put pericranium between the confounding loop as well as the nerve. So, why we had stopped using it? That is one question. And what about the incidence of Teflon granuloma in this present era?
In VHS, at least I can tell you from 1994, it has always been shredded Teflon, and it has been this wide dissection. We never actually interspose muscle or any other tissue, because that all cause increased incidence. We have not had, at least in my knowledge, not even one patient where we had to do. We have had failures where we have moved the one vessel and then probably another vessel is there. This is one, I do not know the exact incidence, but multiple vessels are. So nowadays what I do is, I ask my radiologist to show me a blown up picture of that area. So the last one also I made sure.
Can you see the groove over the fifth nerve?
Yes.
With the nerve?
Yes,
with the
very well shown.
Vessel?
Yes.
So
There are strands which are holding it there. Yes, sir. Can you all of you appreciate the pulsations and how the nerve is moving? It is so clear. But this is not always so. Sometimes from posteriorly, and especially if there is a vein which is bifurcating, and sometimes there is a vessel which goes through the nerve. It goes through the nerve, transfixing the nerve. So these are the various anatomies you must look at before you attempt a microvascular decompression. And I would very highly recommend that original thing. It is our friend in the neurosurgical focus video. It's a neurosurgical focus video where Janetta is being interviewed, and he gives his nuances on this. So I would recommend that today itself you try to see it and learn how this should be done. So sometimes if it is a venous thing or it is multiple vessels, then life can be very difficult. So we have not used, Dr. Salubandin, what about you? Any Teflon granuloma?
When we were residents, it was muscle. Later, of course, once we came out, it was.
So I have dissected off the vessel.
So please encourage your colleagues, those who have not been able to make it, to see these videos. They've been put online, because from the 1994 I have seen that a lot of these things you can only watch them. That is the main purpose of these workshops, is to showcase to ourselves what is the high level of neurosurgery which Indians are doing. And as B.R.M. used to say, that Vellakaran, you should not keep on worshipping them, it is time perhaps that they come here and learn. And this is the cutting edge. With these workshops have been continuously, we run them despite sometimes a lack of response, especially from the city itself. But despite that, we continue doing it because this is important for the young people to see that this is all what you are capable of.
I'll show you that one. Second is, lower down to the breast zone, there is a arachnoid fiber as a part of nerve root.
Actually, some part of nerve fiber
can
is
you
there.
show that
Some
how
is
the-
separated and lift the nerve here.
Yeah, that is what
Next time.
which is holding it also.
Yeah,
Those
yeah.
two are
So
there.
upper side I have cut it, but I will
Yes,
make
sir.
the vascular loop completely free from the nerve
Free from the yes,
and
it is
put up the
gone.
from
Already
from top
free
to
from
bottom.
that. It is
Yeah.
already free from that.
Yeah, yeah, yeah.
The dip, pressure will cast.
Jaiswal sir?
Yes.
Can you just show the how the Teflon is prepared
Yeah, yeah.
before putting in?
Yeah,
That is also very important.
They are giving Teflon.
Yeah. How to make it fluffy?
Actually, it's not fluffy. They just cut it. Okay, that's okay. Make it roll it.
Roll it.
Just hold it.
Roll it. Roll pretty good. Lengthwise. No, cut for ready.
We have a thicker Teflon.
No, we have only this.
Can you make little more longer and like this?
And my fold bunny extra thick.
Just fold like this. Make like this.
Thicker. Thicker.
Yeah, thicker one. From where did you procure this Teflon?
I don't remember. Probably from dentist.
So everybody has their own jugaad. We brought from Japan.
The dentist uses it regularly.
They use Teflon.
Me one roll, you take one roll.
Funny.
You know that? Just 50 rupees it costs.
Yeah.
Yes sir.
Yeah, keep it ready.
I think make a thicker one. Use this one also. Yeah. Okay.
Sir, what to do if we don't get any offending loops during the surgery?
Can you hold?
Jaiswal sir?
Yes.
There is a question from the audience. What will you do if there is no neurovascular conflict?
If no neurovascular conflict, so what we usually you get these cases very rarely, and if you get it, then what you do, just come put your fine bladed forceps and just come over the nerve like this. But I will show you.
Okay.
Are you comfortable? No problem.
Normally here, what BRM used to do, they will catch the nerve with the forceps.
Yes.
And just catch it gently few times, that's all. So that is done, but yeah.
These are enough fibers.
You must search, the first thing you must do is you must search for something below. You must search for something which you are not seeing. Go around the thing, put the endoscope. This is what you should do, because most of the time there is.
Okay, when there is no neurovascular conflict, whether you will really go for an MVD or you will choose any other modality of treatment?
The point is that for the juniors, demyelination. Now demyelination, whether it is caused by this repetitive injury or demyelination per se. So you must realize that the trigeminal neuralgia is a presenting feature in a very high percentage of patients with multiple sclerosis. So we know that. At the same time, as was Dandy's observation and as was the observation of a lot of people who have worked on this is to be done. And when you find that there is no compression, then you look for something. Even then, But then when you are deciding for surgery, I would be cautious. I would definitely not advise this surgery in a patient whom I have not seen any microvascular conflict. Because you must remember that 2% risk is there to life. It's not a minor operation. So that is to be decided. But then you do this. Again, another observation is sometimes just the cranectomy relieves them of the pain. We do not know why. Not even dural opening. Just a small bone piece removal changes the dynamics there probably and does the thing like that.
Okay.
So this is the plan. But whether I answer you, I will definitely not, because in today's medico-legal situation, you have to have clinical evidence that the patient, that's not atypical facial pain. Please make sure that the pain is classical trigeminal neuralgia. You must not treat atypical facial pain. You must not treat other conditions. There can be so many spectrum of disorders which present with pain, atypical facial pain. Then once you have a clinical feature, symptomatology, then please confirm whether the patient has got any signs of trigeminal dysfunction. Please check for little bit of corneal hyposthesia, all that. After that, radiology, please get a dedicated radiologist, neuroradiologist, to tell you, and you also should probably go down to the gantry, rotate the thing, try to see whether anything is there. Some people do an angiogram also. If you read, listen to that lecture by Janetta, they have an angiogram there to try to see that this is the conflicting point with the vessel. So that's going too far perhaps, but this is what all we will do.
Okay.
Sir, have you ever experienced dual?
So we have preserved the petrosal vein, we have separated the nerve vascular loop, we have protected the nerve by Teflon. This is the sixth nerve. Okay, I hope this is all right.
A very, very nice demonstration. So this Dandy's vein, be careful. Sometimes this will have not one, it will have few stems.
Yes.
It will go around the nerve, and damaging this can be catastrophic at times.
Yes.
My experience with MVD is not so extensive, but I will ask Dr. Selvapandian whether he has had dual conflict, both venous and arterial or two artery conflict.
And you can see the dual opening is also very small. Just fingertip. Okay.
Sir, can we move to
this is my index finger.
Sukumasura is performing endofusion?
Right.
I haven't come across dual, but however, like somebody asked, what to do if you don't find a definite vascular conflict. We do what is called as partial sensory rhizotomy, that is infralateral. So, like Dr. Anil said, pinching is one way, or what we have learnt is just cut the pia gently and put a small dissector and just disrupt the things, a small amount, infralateral. The whole idea being preserving the V1 because you don't have a corneal one. Next is another thing which we learned from Dr. Matrichandy was opening the arachnoid very limited amount, because the arachnoid stays like a pouch holding your Teflon pieces. Like this doctor had wrapped one single piece of Teflon while we used to push pieces of it. As you push one after the other, the vessel lifts up from the thing. So we were taught to limit the opening of the arachnoid. Don't open it widely, so that the arachnoid itself stays like a pouch. It holds your, whatever you put in, muscle or Teflon or whatever. So we didn't open widely. We opened limited, and don't even look at the lower cranial nerves. So preserve the arachnoid, use the arachnoid as a pouch to hold it. And suppose you don't find it, or in India, another problem is cost is involved. So despite finding a vascular loop, we used to do partial sensory rhizotomy because most of our patients, when we were back in Bangalore, they used to come from thousands of kilometers. Probably this is the only time they are coming down. So despite finding a vascular loop, we will still do partial sensory rhizotomy, preserving the V1 so that They may have some
in
numbness,
open
but at
surgery,
least
how much you remove?
the pain part is sorted out. This is not the perfect solution, but the practical solution.
So it's always more.
Yeah, Dr. Sudha, we are with you.
Hello?
We are with you.
Yeah, I just done a foraminotomy here. I drilled the superior articular facet and I gone inside the disc space and I am preparing the end plates here. You can see this end plate. Can you see the end plate?
Yes, we can see it.
Yeah, so that's the upper end plate you are seeing nicely. Now I prepared the lower end plate also. I'll just show you in a minute. I'm preparing the end plates. It's an inferior end plate I'm curating out. Already it's partially prepared. So once these end plates are prepared, then we try to come out and do further foraminoplasty if required. This patient has a huge S1 facet, S1 superior articular facet. So it was not allowing our sheath to go inside. So I had to drill the facet partially or to go inside. Now gone inside, can someone show the X-ray image? On.
Dr. Purushothaman, is there anything like a endoscopic micro debrider which we can put into this? It's an avascular space. A debrider would be ideal to debride the entire disc. Is there anything like that available?
Yeah, they do. Now the problem is with the length. The current available debriders, the length is not enough. So we are coming up with endoscopic shavers and debriders now. So we are designing those things. Maybe in 1 year we will get all the tools for endoscopic disc preparation, which can be done faster. Can you see the X-ray image now? Can anyone see the CM image?
Not CM is there on the small thing. We can put it in the center. Put it in the main screen, please. The CM picture he wants to explain.
CM picture on the main page.
CM picture on the main frame, please. Yeah, thank you. It's come.
So we have inside. So again, show the endoscopic image now.
Sir, Pandey sir.
Yeah, tell me.
Dr. Prakash Nair sir is there.
Yeah.
He's going to discuss about the MRI of this acromegaly patient, sir.
Yeah, good.
छोटा देना जो हमारा
Yeah, that's good. You have to. This is how it is to be done. Otherwise, will get delayed.
Pandey sir.
Yeah, tell me.
Sir, I have a question, sir.
Yeah.
We have read about the trigeminal cardiac reflex in the trigeminal surgeries. Although we communicate with the anesthetists that we should be aware of that and we should take precautions. Any experience regarding that, sir?
In pituitary surgery?
Not in pituitary.
So
sir.
I'm telling you, this reflex is something you should be very, very careful here. We have not experienced anything during the posterior fossa surgery. Saying that one thing which I just wanted, because Dr. Selva Pandian, if the CMC Vellore technique was less of arachnoid dissection, here it was large amount of arachnoid dissection. And I'll tell you what happens. The arachnoid itself is one of the offending features in this. It keeps the vessel towards the nerve. I did it day for yesterday. So once large superior cerebral artery indenting the nerve. So once I freed the arachnoid and then I just pushed the thing, the whole thing literally recoiled away from the nerve. That recoil away from the nerve is actually the surest way, and we don't put bricks of Teflon, we always shred it. Even Janetta says shred it and put, because the bricks have a tendency to slip. The shredded one you can rotate and keep away and then they stay there. You probably need to wait for some time for them to happen, and that adhesion work, by the time you are checking hemostasis, that will sort of get adherent. It's not easy to remove the thing, so that is what we do.
Professor Pandey.
Yeah, tell me.
Though now it is not my topic, but I have done around 60 to 70 microvascular decompressions.
Yes.
The answer to the question is I had 2 cases where patient had a severe brady while handling the trigeminal nerve.
Okay.
So you need to be very careful when you are dissecting the trigeminal there and trying to mobilize the trigeminal nerve. So patient can go for sudden severe bradycardia. So I had 2 cases where the brady went to.
But what I would say here is, for the youngsters, you are not supposed to be dissecting the trigeminal nerve.
Not resecting.
Dissecting, not dissecting. I said dissecting. You should not tug it. You should not traction it. You should do that with the arachnoid and with the offending vessel.
Yeah.
The nerve should not have anything.
We should caution the anesthetist that you are at the main area. So what happens sometimes anesthetists are not there. Then we should caution them to be there so that at that side of the patient, this can happen anytime.
Dr. Prakash, yeah, you are audible.
So, a very good morning, sir. I shall be starting this case. This is the case of a...
Your images have not yet come on. Professor Prakash, ask them to put the images on the...
So the image will be on screen in a minute.
Yeah, please.
So this is the...
Regarding any
patient who has acromegaly and...
okay.
So now I'll come out further and start...
we are not able to see the screen. Please ask them to focus.
Yes, sir.
Hello? Okay. But regarding any posterior fossa surgery, if you retract anything, there will be a bradycardia because the brainstem reflex will be there. That is, we have seen always, we caution the anesthetist. Anesthetist in fact will caution us, your pulse is coming down. That always we have seen. And there is alarm. That is the time you have to stop any retraction or any handling of the tissue around the brainstem.
See, in open surgery you don't see whether your end plates are well prepared. Some bleeding you are happy.
Yeah, you are on, we can see you now.
So, I shall just go through the scan of this 40-year-old female patient who has acromegaly.
Okay, so end plate preparation is good enough.
A prior transcranial approach for the part which had occupied the lateral to the internal carotid artery. And at this point of time, she has a large mass inside the sella, and it is extending into the cavernous sinus on the right side. So, this is the MRI. One can appreciate both the carotid arteries. One can see that the carotid artery on the right side has a slightly more tortuous course compared to the carotid artery on the left side. The pituitary adenoma has extended into the cavernous sinus. This is a NOPS4 type extension, where this is involving the entire circumference, 360 degrees of the carotid artery on the right side. Now, we all know that the carotid artery divides the cavernous sinus into 4 compartments. There is an anterior-inferior compartment.
That time we partially drilled, right?
There is a lateral compartment and a posterior compartment. And this is the part of the tumor that is extending into the posterior compartment of the cavernous sinus, and then further on, probably still lying intradural, within the cavernous sinus, but reaching up to the posterior fossa. And this lies close to the point where the 5th nerve occupies the Meckel's cave. So that is the anatomical relationship of this tumor. This is the central part of the tumor that is middle to the carotid artery. This is the tortuous course of the carotid artery, and this is the tumor occupying the posterior compartment of the cavernous sinus. So in this particular case, the focus will be on using a transpterygoid approach, which is to take this wedge of bone here so that one has access to the lateral compartment. One is able to see more towards the sphenoid, to the lateral wall of the sphenoid sinus, and access the tumor that lies on the lateral aspect of the carotid artery. Now, it should also be mentioned that for functioning tumors, for otherwise non-functioning pituitary adenoma, there is really limited indication for exploring the cavernous sinus, and in most cases it can be managed by imaging follow-up or by adjuvant treatment, because this is a scenario where there is a greater instance of extraocular palsies when we explore the cavernous sinus. However, for patients who have uncontrolled functioning tumors, there is at some point of time some indication of exploration, but this should still be done in a very cautious manner, because the patient has a very real chance of developing an extraocular palsy. So that is one of the problems that may occur with the surgical approach. So a conservative resection and management of the residual with radiosurgery would be the ideal balance that one would strive to achieve for a tumor like this. Now, when we consider this tumor, one of the things that we should look for is the shape of the septum. In patients with acromegaly, there is often hypertrophy of the middle turbinates, the inferior turbinates, and there are instances where there is septal deviation. When one decides to do a transpterygoid approach, it is almost understood that the sphenopalatine artery on the side of the approach will be sacrificed. And in that particular case, one must be aware that the flap should be raised from the opposite side. So, if we consider doing a flap, the flap should be done from the left side and not from the right side. So this is the coronal image, and one of the things that we can see in this image is the location of the ICA. So this is the laceral segment of the ICA becoming the paraclavial segment of the ICA on the left side, and this is the course of the ICA on the right side, and one can appreciate the tumor extending lateral to the ICA all the way close to the laceral segment. So these are considerations that one would have to keep in mind while exploring this patient.
Mangal, please have the cases which you all have been prepared. Before every case you can have the case thing presented, because that has not been done. So make sure that from this thing is done. We've already got all that thing presented, no? Then why is it, you should already put it, no? Please have that put from now onwards, huh? There should be a, whenever we have a little gap, please have the case, the images and the case history presented of this patient. Dr. Krishna and me operated on this patient, and we were able to resect a significant amount of tumor, but we could not go beyond that. We entered into the cavernous sinus as much as possible from the T-renal, but at that point itself I was debating whether we should have gone initially from the transnasal midline approach, but probably this patient required both these approaches. Any more comments on the trigeminal nerve? Sometimes the sectioning, so now the portio minor and the portio major, you people must know the anatomy, microvascular anatomy and the anatomy of the nerve very, very well. But generally as a rule, sectioning of the nerve is not practiced. I have not seen it now. I think probably somewhere in the early 90s we saw it. After that it has never been, no incision has been done. It has always been, the worst case was to just compress it and see.
Sir, we can switch to OT4, OT3 where Sukma sir is doing the endofusion.
Yeah, can we have the endoscopic view in the main column? Hello? AV team? Sukma sir? Hello? Sukma sir? Yeah.
I am doing foraminoplasty. I'll just show you.
So did you see the exiting nerve root while putting your sheet, while going just in before the disc base?
I'll just show you. Yeah. Yes. I'll just show you. You can see at 3 o'clock some fat here.
Yes,
can
sir.
you see
Yes,
the
sir.
fat?
Yes, sir. Yes, sir.
Yeah, that is the exiting route.
Okay.
Fat. I just rotate the sheath. So that fat is covered, the exiting route is covered by the fat.
Yes, sir. Yes, sir.
So I just you can see my sheath is protecting
the nerve. Yeah.
I'll just overpass it. So this is a disc entry. You can see the disc entry.
Yes.
I've already done the in-plate preparation. I'll just show you once I go in. There is a osteophyte here. That's why it's not allowing to go in. And this is a facet I have drilled at 12 o'clock. 9 to 12 or 9 to 1 you can see. That's the facet I have drilled here.
Non-articular part of SAP.
So that I am just using upcut to remove further.
Okay.
So this has been removed adequately. Now I can insert a cage easily inside. So the end plates are being prepared. I'll just show you the end plate preparation also. RF. So once I make a space for the cage entry, it's easy. The traction on the exiting route will be less.
Okay, sir.
So I'll just focus here on a little bit drilling this part of the bone, drill, and we'll go in and show. I'll show you the end plate preparation.
What is the drill size what you are using now?
2 mm, the drilling surface area is 2 mm.
Okay, sir.
So 2 mm drill I am using here.
So that's the base of the SAP, non-articular.
Yeah, base of the SAP, drill the base of SAP.
Okay, sir.
And the free end of SAP.
Okay, sir. Okay.
And chopped off the tip of SAP with the chisel, so that was missed. So I'll just show you once this bleeder is taken care of.
Okay, sir.
So stop. The tip of SAP was here, which has been removed.
Okay.
And that's why the fat of exiting nerve is getting exposed.
Yes, sir.
So this is a ligament which will usually be there.
Protecting inferior ligament.
Yeah.
Just below the nerve. Okay.
So now this is a disc space.
Yes, sir.
So we have to enter here. I'll just enter and show you the.
How to ascertain whether the end plates are completely prepared using a 0 degree scope?
This is it possible? 0 degree. This is a.
This is 25 degree.
Yeah, yeah.
Okay,
so you can see, right?
Yes, yes. Okay, fine, fine.
You can see what you have done. Upcut, punch and upcut. Yeah, I'll just show you. Come out because a discussion was going on. I didn't want to disturb. So, what are they not? You must be working very well. Upcut. There is a osteophyte here at that foramen area. That's why it is not negotiable there. So just I'm removing that osteophyte.
The outer sheet is 8 mm.
Yeah.
Okay.
It chiseled in. Chiseled in. Favorite. Drill. I have removed the disc and prepared the end plates. I'll show you.
Yes, sir. Does the outer sheet need
outer
to go inside the disc space? Till that's your end point of drilling?
You can see here this end plate is a lower end plate. Can you see the lower end plate?
Yes, sir.
Stop the saline here. You can see the petechial hemorrhages of the lower end plate bleeding.
Yes, sir.
Then this is the upper end plate.
Yes, sir. Yeah.
So I prepared well, and this is anterior annulus.
Yes, sir. Could see.
This is anterior most annulus. We have gone till the anterior most annulus.
Yes, sir.
And shoot panni.
Beautiful demonstration. I actually am amazed. Very well done.
Thank you, sir. So shoot. So shoot.
So how do we prepare the end plate, sir? To scrape off the disc, what do we use, sir?
Shoot. You can see there, can you see the CM image?
Please.
CM image bigger.
CM image in the main screen, please.
Now I'll start packing the graft here, because we have done a good interbody work here. Now all we need to pack the graft here. So there are various ways of packing the graft. One, you can use a autograft taken from the iliac crest of the patient. Again, that will be painful. Second is allograft. Now you have a lot of bone banks where you get allograft. So you can get allograft, and allograft is very safe now. We can use allograft. So this is a curette I used to prepare the end plates. It's articulating curette. You can see it's nice. End plate is getting prepared. So we can use this to prepare the end plates without damaging the end plates. In open surgery, we always do it blindly.
Yes, sir.
Even in MIS also, that's always there is an injury to the end plates, or we are not prepared. We remove the end plate cartilage, so the preparation is inadequate, and there is a migration of the cage. Here you are dead sure of, damn sure of preparing the end plates nicely. How much is prepared, you know how much you have prepared. You can see here, nicely prepared. So I will pack the graft now. So section, long section, AP. I will take a bone marrow from the iliac crest of the patient and mix it with the allograft. Hinge coming. So now I will take make that PAP bigger, the image bigger. PAP image bigger. Focusing.
It's very, very important for all of you to remember that iliac crest graft complications are a huge source of litigation in the US. And just watch him. In fact, I would like him to show you how to take a bone graft, because this is all important. You should know neuroanatomy. In fact, the Benzel's complication in spine surgery, please go to the chapter that is in the second volume. You have a chapter telling you how to reduce the complications. You must know where the cluneal nerves are. You must know how to harvest graft. And these are all part of the, your practice. You have to do it yourself.
Now here I am taking only bone marrow from the iliac crest. Then after taking bone marrow, I will mix it with the Kronos. It's a synthetic graft.
Is it like G-bone?
Can you suggest? No, it's not G-bone. Focus panninga. This is by Synthes company, Depu Synthes. Konja dull pannunga.
Okay.
So
you get that bone brick, you break it into multiple pieces.
Tricalcium phosphate crystals.
Okay.
I mix this with bone marrow.
Bone marrow blood. Okay.
Taken from the iliac crest. So I'll just go with the shoot. Shoot panninga. No, all sound varudhu. Shoot. Shoot. I just go take the from the iliac crest with a Jamshedi needle, putting using a Jamshedi needle here. क्या बोले जाए ना shoot. 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 The height panninga. Son, take it. So you can see the bone marrow coming here.
Yes, sir.
Can you see the bone marrow?
Yes, sir. Yes, sir.
So take 5 cc of bone marrow and mix it with the crystals. So I take this 5 cc of bone marrow, mix it with here, you can see the mixing it, remove this. Now I pack the graft anteriorly, you can see how I pack here, okay? Spoon kodunga, spoon. So I'll just pack this graft anteriorly, lateral CM edikuringla.
Working channel.
So I just push the graft anteriorly, lateral. The graft, they say again there is a debate how much you pack, 5 cc, 6 cc, 10 cc, but you ask any shoot.
We are not seeing the CM image.
Yeah.
In the
Show the CM.
PIP. Not very clear. Yeah.
So the graft is packed as anteriorly as possible. Shoot. Can you see the graft coming out there? Small
Yes, sir. Slowly.
shadow coming out there.
Yes. Anteriorly.
Anteriorly.
Yeah.
Shoot. Shoot. So debate is that MIS surgeons they pack around 3 to 5 cc normally in MIS T-lift, So they say that is adequate. Some people I pack around 5 to 10 cc. So now we have taken here 5 cc of graft. So it's a smaller space, 4 to 5 cc. Bigger space, you can pack 10 cc. Shoot.
Okay.
Because you prepared the end plates well, so it takes more graft. So I have almost packed 4 cc of graft here. So I'll just take a final shot and come.
How do you select the cage size?
Cage size here.
Outer sheet is gone. Outer sheet is gone, so more than 8 mm.
Yeah. So outer sheet is 8 mm. It is snugly fitting. So I'll take 10 mm here.
10 mm.
Can you see the graft there?
Yes, sir. Yes, sir.
Yeah.
Yeah.
So that's a graft packed anteriorly.
Yes, sir.
So now I'll dilate it. Dilate this dilate. ಹಿಂಗೆ ಕಾಮಿಂಗಿತ್ತು ಸೊರಗುಟ it will sit there. The graft is very nicely sitting anteriorly.
Okay.
K-wire. Now because I know we have drilled the bone well, the sheath was sitting there for almost 30 minutes. So you have a separation of structures, muscles, and the nerve is gone away. So again we put a guide wire here. Over the guide wire we'll put the cage.
Okay. Can you show that, sir?
Yeah, I'll just show you. So now the guide wire which we use for the cage, the same guide I put, and I'm just removing this. Shoot panninga. So
you need to remove the sheath, then only you can put the cage.
Yes. So I removed the sheath now. My guide wire is sitting in the disc space.
Okay, yes.
So if I insert a cage, it goes on the.
Okay. Will you confirm by CM now again? Will you confirm that it is in the disc space? So will you confirm by taking a CM now?
Very important to you. Yeah, CM, show the CM.
Take a shot.
मैं तो पात्र किया हैं?
No, the CM image is gone into VIP mode. Can you bring the CM image in the main screen?
यार senior sister virtual
Yeah, okay, fine. Sure. Show the surgical field.
யார் எடுத்தாங்கம்மா கூப்பிடுங்கம்மா கீழே பாருங்க சீக்கிரம் வாங்க அது இம்பார்ட்டன்ட் அதே நீங்க देखना कभी बाहर से So now here I'll put a dilator so that the track forms and it dilator then do dilator then. Can you see the K wire there?
Yes sir, we saw the CM shot.
So what I'll do is I'll just put this MI screw dilators knife here, so that the muzzle is retracted and
cage can go freely.
Adana tambi. இவ்வளோ பெருசு இதில் எப்படி தான் இருக்கும்? அதே எடுத்துங்க, அதே நீங்கள் அதே எடுப்போம், அதே எடு. அது பாருங்க, அது ஹேண்டில் உடன் ஒன்று தான் வந்திருக்கு. Knife. So now I am putting the dilator. There was some confusion regarding the cage holder, so we are just searching for that. So in a conference always this happens, things get missed. So what I am doing is I am just putting the dilator. So how does this help? They help in two ways. One is assessing the diameter of the cage to be put, shoot. That is the first dilator I used.
Show the CM image, please.
Second dilator is the 10 mm dilator. This is the 10 mm dilator I have placed. Shoot. You can see the 10 mm dilator going there,
yes,
just
sir.
below the shoot facet.
Yes, sir.
It has gone there, so I can use the 10 mm cage easily.
Okay.
So this helps in retracting the muzzle and it stays there for a while.
Okay.
नहीं छोड़ उनको सब वो लिखेंगे. Now I will show the cage here. You can see the shape of the cage. Can you see the shape?
Yes, a bullet cage, right?
Yeah.
Yes, sir.
So you can see this is a cage.
Okay.
As we use in open surgery, but the tip is little bit more tapered, so that it is like a dilator.
Oh, okay.
So this
yes,
goes on the K-wire, and when it goes in, it just spreads the tissues.
Okay.
It never lacerates the tissues.
Okay. Yes, sir. Yes,
And the other things are same. It is 4-degree lordotic cage. So I'll just insert it now. I'll remove the dilators.
Okay.
The muscles might have dilated further, so I'll just remove it.
Okay, packing some graft within the cage also, right?
No, I don't pack. Some people pack, but what happens when it going inside?
Okay.
It is going on a K-wire.
Okay.
So what you say, the graft falls in the muzzle and sometimes in the foramen.
Okay.
So that's why I don't pack the graft. Allograft, it is okay. You can pack allograft or autograft. So you can see now it is going on the
yes, sir.
guide wire. I am just going in. Show.
CM, please.
No, you show the CM, only CM images. Shoot. Shoot.
Yes.
Okay.
Yes.
Now it has crossed the facet and it's just sitting snugly on the disc space and just going in further. Shoot. You can see there it's just entered the disc now.
Yes, sir.
Remove. Now I just go in. Shoot. Okay.
Yes, sir. Yes, sir.
I gone inside.
Inside, yeah.
Compress करनी है. Now I will take AP. Now it is snugly gone. I can go further anterior little bit more.
You have to turn the cage also, right, towards the opposite side.
Yeah, that already I have done it. So you can see now in AP. Because the facet is there, you cannot too much middle. You can see there.
Yes, sir.
It's almost gone to the midline.
Midline, yes.
I can just hit some more lateral kudunga. Lateral. Faster varninga. Slow movement varakuda. Fast. Should be fast now. Shoot. I'll just go further anterior.
Okay.
Shoot. Can see?
Yes.
I've gone further anterior now. AP.
Yes.
Faster. Here CM technician should be really trained, otherwise the traction should Can you see here?
Yes, sir.
கொஞ்சம்
Yes, sir.
பின்னாடி போங்க. Shoot. Okay, the cage has crossed almost, it's in the midline. So
Yeah.
this I take it as okay. I would have been more happy if it has
Till it
further.
cross the midline.
Because of the facet here,
Okay.
I am not able to medialize. But this I take it, I am okay. So here it's okay. I'll just take AP and lateral again. Shoot. Lateral. You need to see how deep it has gone here. It would have gone very deep.
Yes, sir.
Because we have gone almost as anterior as possible. Shoot. You can see here.
Yes, sir.
And gone much anterior.
Yes, sir.
And nicely the space is created. And see the foramen. The foramen which was there before,
It
and
has
foramen
height
which
has
is now
increased.
the height has increased.
Height has increased.
Yeah. So now we'll put a now we will just put a scope and see whether our structures are safe.
Okay.
Not. We'll just check it.
Okay, sir.
Shoot. Sheath. Shoot. The scope. I'll just show you where is the cage and how is our exiting now route.
Okay, sir.
Endoscopic
view, please.
Can you show the endoscopic camera?
Endoscopic view, please.
While putting the cage in, is there a possibility of injury to the nerve root, sir? Because when we are endoscopic, we were protecting the nerve root all along. When the cage was being put inside, there was no sheath to protect the nerve.
Yeah.
So the serrated edge, can it injure the nerve or no?
No, the moment the dilator, the what you say, the front 7 mm what we have made, so once it goes inside, it distracts and everything is pushes the nerve and it doesn't lacerate the nerve because it's like a dilator. Camera light source on பண்ணுங்க தம்பி.
The endoscopic view, please.
Yeah. நீ என்ன பண்றடா? Light source on பண்றா. Where is the light source? That's what I'm asking you. You are always on the phone, not working here. Punch. Can you see the endoscopic image?
Yes, sir. We could see that.
So I can see the some fat. I'm just removing the fat. Saline increase பண்ணுங்க.
We could see the cage.
That's a cage there.
Yeah, and yeah.
You can see the nice flat globules there.
Yes.
So that's a cage. So
Yes,
I'm
sir.
just coming out to show you that's your concern of exiting road.
Yes.
So that's the exiting road. Can
Yes,
you see
sir.
at
Yes,
3
sir.
o'clock?
Yes, sir. Yes, sir. We
That's
can
the
see.
exiting
Yeah.
road. Fat is intact.
Yes, sir.
This is exiting road. The fat covering. This is exiting road.
Okay.
Okay.
Yes, sir. Yes, sir.
The
Yeah.
pulsating thing is the exiting road,
Yes.
which are not being lacerated here. Okay.
Okay.
So now we are coming out. Just coming out.
What is the flow rate of saline you use?
Huh?
What is the flow rate of this normal saline? The flow rate?
Flow rate. We are using a different pump here.
Okay.
This Arthrex pump we are using.
The Revo one.
No, this Arthrex company. It's one more company. So now we have done with the cage placement.
Okay,
We'll just now put the percutaneous screws and come out.
Yeah. Okay, sir.
Okay.
Do you do neuro monitoring for your cases?
Yes. I always use neuro monitoring. When I'm inserting the cage, my neuro monitoring guy will help me. So whenever he says that there are a lot of signals, when we don't insert the cage, we put the scope again, do further foraminoplasty, remove the facet further, and insert the cage.
That is the point which all of you, are you understanding? That is, you monitor the patient physiologically. You know that the instrument has already been adjusted to avoid root injury. But in real time we can do that. And sometimes literally I touch the screws. You can stimulate the screws and see whether you are touching and irritating the nerve root. So you are able to do that. Remember that a simple lumbar microdiscectomy can give rise to the cauda equina if you injure something. A simple lumbar disc can mar the patient for life. I had a patient, a father, who had a huge trophic ulcer, a foot drop after a disc surgery, and he brought his young son, about 21 or 22, with a huge disc prolapse, again developing foot drop, but he did not allow me to operate on him because this patient, he was done a few years back. So now you can understand, because he feels that this his son of his also will get the same trophic ulcer and will suffer with that non-healing ulcer for years. So even for a lumbar disc, in a setup, I use neuromonitoring. So that is how retraction is totally taken off, because when you retract these nerve roots to get into the disc space, you will realize that the person will tell you that, sir, there is lot of disturbance, there is lot of disturbance. So then you become more careful and you do not retract and make this procedure also very safe. This I think you all should watch carefully. This is a screw, yeah, how a screw is placed. All of you can, and you can feel free to ask questions, because that is how you will learn.
So for normal transforaminal discectomy, do you use GA or you do it under local? Sukma sir? Sukma sir?
Yeah.
For the normal transforaminal discectomy, do you use GA or do you do under local?
Hello, can you hear me?
Yes sir.
Yeah, initially when I was learning transforaminal, I started my career with transforaminal in 2013. Okay. Then I used to do only under local. Okay. So from 2015, like 2 years later, since then I am doing under epidural. Okay. So I always do under epidural.
Okay sir. Yeah. Okay. Why you are converted from local to epidural, sir?
The journey of the surgery for the patient is very, very traumatic and painful. Patient will be, some patients are very, they will be jumping on table, and as a beginner you are also very frightened, and you can injure something when patient is moving.
Okay, sir.
So epidural analgesia is a very good tool. You can do wonders with that, and whenever you want you can convert into anesthesia, epidural anesthesia also.
Okay, sir.
Actually, so epidural I do, but local is also okay if you have a very good anesthetist where they can manage sometime propofol or dexametamidine, they can manage with that, then local is also okay. Or guide wire which part, put a guide wire inside and see.
For the younger people, this new second revival of awake craniotomy is basically waiting for another death. Because as soon as neuromonitoring reaches the level which is better than the awake thing, definitely every patient, if you ask me, I would refuse to have a awake craniotomy, because it depends on the personality. So you should see from the patient's viewpoint, awake is not comfortable for most. There are people who like jumping from aeroplanes. So you have a lot of people like that who like taking risks. But that is not the story with all patients. So that's why we don't see so many people advocating awake spine surgery. So all those things are a lot of problem, because it creates a lot of stress, subconscious stress on the surgeon. And obviously it's a huge stress on the patient. Actually there should be proper psychological assessment done. How much of a strain we put on the patient by making him awake. So once monitoring becomes real time and very good, again this will become obsolete. Anesthesia has been invented.
See, the proper problem with the monitoring is that we still don't have anything ideal for language. So that is one of the main issue, and I don't think there is anything in the near future which is going to replace that. So if you want to monitor speech, everything, I think it's going to be okay.
Rescue. That is what the modern neuroscience and these connectomes which are coming through, that knowledge is going to transform that. So as of now, the connectome knowledge and physiology, that brain mapping is, I think, nearly reaching there, and my prediction is in about 3 to 5 years you will be there and you will be able to judge that changes very easily.
Inferiorly karna dekh raha hai. Then remove the K wire.
What is the size of the screw you are using, sir? Sir is putting.
थोड़ा ज़्यादा ही जा रहा है. Huh?
It is going very close to the superior end plate.
Yeah. We can change the direction if you want.
Okay.
We can just come out and.
So what do you feel, sir? It has to be parallel to the superior end plate, or it has to be in the midway? Because
no, it's okay because they say the upper end plate is the strongest
yes, sir, because you have cortical bone there.
Yes,
so it
yes,
purchases some cancellous, some cortical bone.
मैं क्या बोल रहा हूँ, निकाल के 40 डाल देते हैं.
What is the size you are going to use?
40. We are putting 40 here.
Diameter. This one.
40.
6.5.
6.5 40.
6.5 40. Okay.
So लॉक பண்ணிக்கோ 40 डालो बोल रहा वही बोल रहा हूँ 40 डालो तो चले जाएगा. So my colleague is putting the ये निकालो disconnect कर लो. The K wires, Dr. Gaurav is applying putting the screws. 40. So actually we thought we'll put a 45 screw, but because of the end plate issue, we are just taking a smaller one. Wire थोड़ा पीछे खींच ले, guide wire पीछे खींच ले. Short. उसका है क्या? नहीं इसका ही है. Here again, as a beginner, you should remember when you are doing this. K wire starts, you can see the K wire is going anteriorly.
Yeah.
So you should be very careful. Careful seeing the guide wire all the time, otherwise it might go anteriorly and injuring the retroperitoneal structure or intraabdominal.
Do you catch the K wire at the end with the cocker?
We can do that, but sometimes that helps, sometimes that doesn't help.
Oh, okay, fine, sure.
So always be careful. ठीक है रे, क्या कर दिया? ठीक है ना? हाँ? कुछ नहीं है, ठीक है. Short. Yeah, it's okay.
So this is 40.
40. She is a very obese lady.
Okay.
The male, obese male.
Okay.
Here 40 ले लेना. Here the challenge would be the iliac crest was coming in the way. So when we are putting the dilators, sometimes the last dilator doesn't go. So then we have to use only 3 dilators.
Yeah, that's why the regular transforaminal route is this iliac crest can hinder for discectomies.
Yes.
Yeah.
No, should lock பண்ணுங்க. Just do in this position. Don't keep on changing the position.
S1 it has to be bicortical purchase, right sir?
Yeah. Always possible try to have a bicortical purchase. Should. As I said, the iliac crest
is hindering your
sister. It's gone in. Yeah. யாராவது Sun cook, Krishnan cook, someone washes him with him, hold பண்றதுக்கு easy. மொபுசு பண்ணி வந்திருக்கேன். So implant related issues direction should. This direction should be in line always. You should not change the trajectory of guide wire so that guide wire gets
broken
and guide wire starts going anteriorly. Should be very careful.
Okay.
Junior person wash panna, I will help. So we are putting 6.5 40 for the S1 also.
Can be bigger also, right? More than 6.5.
थोड़ा लूज कर लेना, थोड़ा लूज कर. हाँ, मत सिस्टर कर. Yeah. The minor things. So you can see the bicortical purchase there.
Yes, sir.
Yes, just pierce the anterior cortex also.
Yes, sir.
Yeah.
Bigger screws can also be used, sir, at S1.
This is 6.5.
7.5 also you can use?
Yeah. I always prefer 7.5.
Bigger the better.
But the problem is you want to have a rescue screw.
Okay.
So that's why the last screw should be left behind. So use 6.5.
Okay.
Any problem you take a
7.5. Okay.
Bigger screw. So rescue screw should be always there. So.
Okay, sir. How do you feel the bone quality? This osteoporotic while
it's porotic, not very strong. That's why the plan was to take little bit cranially, so to have a better hold.
Better hold, yeah.
Yeah.
What is the implant, sir? A Jesco or anything different? Sir, what is the implant being used, sir? Is it Jesco or Gion?
Huh?
The implant used?
Gion. We are using Gion company.
Okay.
So the cage has been devised. We designed this cage, manufactured by Gion company. So myself and Dr. Mahesha, we both designed this cage. So we are using this for past almost now 5 years now. I have done around 75 cases and Mahesha has done around 60 cases. So we are publishing our results the past 4.5 years now. So we have excellent results. No touchwood, no case migration till now. That's the advantage of transforaminal route, insertion of a transforaminal route.
Thank you, sir. Thank you.
40. थोड़ा इधर इंफीरियरली करके केवर निकाल के, हाँ थोड़ा इंटरनेट पर निकाल दो केवर.
So at what point you remove the K-wire, sir? Just while reaching the tip of the K-wire, you remove the K-wire, and then you continue to.
Short. Now you just little bit remove the K-wire now.
Yes, sir.
Slowly changing the trajectory. Shoot. You can see that it is coming little bit inferior now.
Yes. Okay.
Shoot. You can see this is ideal entry what we wanted.
Okay.
Yeah. Okay, Lamachi. This is ideal entry. So we need to know the rescue measures also.
Okay.
Vegamo. You assist him. Sister in Kelavan. Sari. Remove that foot pedal. क्या? अंदर चला गया? ठीक है, कोई बात नहीं. है? just இங்க ஷோட் என்ன ஹேண்டில் கொடுக்கணும், என்ன பிளேட் ஹேண்டில் கொடுக்குறீங்க பாருங்க நீங்க. ஓகே ठीक है. ஹேண்டில் வேற கொடுங்க, ஆனால் அந்த ஹேண்டில் பிடிக்க மாட்டேது, வெளியில் வருது. ठीक है. तो ब्लेड हाथ से लेके कर देना हो, नहीं तो बाहर ही है ना हैंडल, अदे हैंडल वेच्ची कोडुंगम्मा. शीत आया नहीं नीचे तक है, आया क्या? यहाँ पे भी केवर निकाल के, ठीक है ठीक है. So the common problems here are while putting percutaneous screws, your guide wire may go anteriorly, or you have too oblique. Then while you are removing the cap, your K-wire might come outside. Once a K-wire comes outside, it's again you have to go through the same process again. So should be very careful. This is a time when you get fatigued and the problems happen. So should be little bit slow here doing things.
Can we see the surgical field also? Camera?
Angika. थोड़ा बाहर है shoot.
Yeah, the Siam image please. Siam image please.
Siam image. AP. AP பண்ணிட்டு திருப்பி லேட்டரல்ல வெச்சிருங்க ஃபாஸ்டா. ஷூட் பின்னாடி போங்க கொஞ்சம். ஷூட். Yeah. It's okay? Can you see the screws here?
Yes.
Yeah. So
nothing is going towards midline.
Lateral.
Yeah. The left side S1 screw, can it be more medialized, no?
Here because of the iliac crest,
that's why
we are not able to medialize. The high iliac crest is riding.
Okay.
Not able to medialize the screw, but it is inside the pedicle.
Yeah. Yes. Sir.
Okay.
Okay. Now putting the rod is the same system as the one in Medtronics, the Saxton system, or it is slightly different here?
That is okay.
Yes, sir. Sukma, sir. Putting the rod.
Yeah.
In this Deon system, is it the same as the Medtronics, the Saxton type?
No, this system is very easy because this is the Viper system, Indian made. So this system is very easy, where you need not require one more hole.
Okay.
This is very easy inside. So that you're taking a 40 rod now. Remove the mop.
Remove the mop, please.
Yeah. See how he is inserting. There is no need for one more hole.
System.
It goes through the same hole. Rotate कर ले रहे.
What will you do if you have a longer constructs? How do you put the rods then?
You can do this. How you put a
same like
scoliosis surgery where we put a longitude, where you put a rod. Just keep on negotiating and inserting and checking the rod.
Okay.
It's very easy, very easy.
Okay, no separate incision here. Okay.
It's checking the rod, so it is there, and you can see also. पकड़ना है. See, when it's tightening, that rod goes away. So you should pull it and keep it, doctor. Should. No, this will come out. அப்படியே பிடிச்சிக்கோங்க. Yeah. Short. शॉर्ट उस तरफ का डाल देता है इट्स नॉट गोइंग दैट स्क्रू का एंटर नहीं हुआ है दैट शॉर्ट एक बार एंटर हो गया तो हाँ भी जाएगा शॉर्ट
It is at the same point.
Want me to help? ಬ್ಲೇಡ್ ಓವಲ್ಲ ಇದಿಲ್ಲ ಇನ್ನೊಂದು ಬ್ಲೇಡ್ ಒಂದಿಚ್ಚಿಲ್ಲ ಎಣ್ಣೆ ಹಚ್ಚಿ ಹ್ಯಾಂಡಲ್ ಹಾಂ ಓಕೆ ಕೀವ್ ಇಟ್ section ठीक है short
CM image please.
short short not going section शॉर्ट मैं उधर का डालो पहले जा रहा है कि नहीं सेक्शन इनमें सेक्शन इल्लिया सो
Can you show the surgical field?
Yeah, 1 minute. We'll just showing. So
we're just seeing how you are negotiating.
Sure. Yeah. No. Suction, amma. Scissor, curved scissor. और knife है कुड़ूंगा ना? Knife.
AV team, can you put the spine CM image on the main PIP?
Bipolar? What is phenopolitan? It is not distal phenopolitan. Bipolar. On.
AV team, can you put the spine CM image in the PIP, main PIP?
Just give me a minute, I will orient everybody to the field.
Okay.
Just 2 minutes. After.
So we'll go to the spine theatre and come back.
Yes, that's it. What happened?
Okay. Sure.
Can you show the surgical field?
Sure. Where are you? जा रहा है मेरा टाइट हो रहा है शूट
See arm image.
शूट इधर कर देना पहले इधर का डाल दो पहले சரா சீக்கிரம் வாங்க போதுல जा रहा है शॉट शॉट
Yeah.
इधर कर short.
Yes, sir.
So what was causing the problem was being a highly lordotic lady, male, with a high iliac crest. So there was a thick fascia which was not allowing that rod to sink in.
Okay, sir.
So what we did was little bit did a fasciotomy there. Then the rod went inside.
Okay, sir.
निकाल दो ना ये करता हूँ तो मैंने scissor knife लेना था मुझे knife में इधर नहीं जाने के लिए इसको थोड़ा बढ़ाना है ना short checker something short short हो जाएगा short
और पोर दांगे
short ठीक है नो प्रॉब्लम थोड़ा अंदर करना है ना शॉर्ट थोड़ा हैमर hammer. ठीक है. Yes. Any?
Can you show the surgical view?
है 100%. பண்ணுங்க ஒன்றும் ப்ராப்ளம் இல்லை, பண்ணுங்க. கேபி ஆக்கிங்க பரவாயில்ல. Just we are taking a check AP whether before tightening, final tightening, whether rods are in place, anteriorly or rod is there or not.
Yeah, okay. Could the cage could be little in midline, but
yeah, I told you right in the.
Yeah, you told me.
It's okay. It has come till midline, and we are more anterior, so this is okay. And we have packed the graft well. You can see medial to the cage. You can see the graft.
Yes.
So you can place the graft well, so no problem.
Do you compress while tightening?
We'll do it because when I hit the cage, it went in very easily, even the 10 mm cage.
Okay.
So just small compression. It's
okay.
Lateral extension. But there is no need to compress here because we have a good facet support. You have not violated the facets.
Yes, sir.
So sometimes we call it as a facet sparing fusion.
Yeah.
So
we just drill the non-articular part.
Yeah. So that's why there is no need to worry about the sound. टाइट कर कंप्रेस करने से जस्ट टाइटन इट फाइनल टाइट इसका और जा सकते हैं नहीं बेटा ये बैठा है ठीक ले ले फर्स्ट कर देते हैं ब्रेक करिए நல்ல மாப் கொடுத்துறீங்க சிஸ்டர் Goes. Will okay. Yes.
Taking your hand.
Mop amma nalla mop koncham saline vechittu kudicha.
You are taking any final shot, sir? CM?
Yeah, I will take a final shot here. Shoot.
CM, please.
Yeah, that's a final shot. AP. Yes, that's a show that. That's a final shot.
Yes, sir.
Yeah. So cage is way anterior. Foramen is opened up.
Opened up, yeah.
And we can show the images here. Saline mop amma konjam tadichi.
Yes, sir.
Wow.
Excellent, sir.
So,
yeah. Show the AP.
Yeah, we'll just show you.
Yeah.
Shoot. No, this one. இது உள்ள வரணும் அது கொஞ்சம் இது பண்ணுங்க இப்படி ஷார்ட் உல்டா பண்ணு here the table we are adjusting the correctly short
Yeah.
This midline you can see interpedicular distance is good. The screws, the one screw as you said, it
Left,
would have gone further medially.
Would have medially angled.
Yeah. But it is inside the body, so we need not worry.
Okay, sir.
So here you can see the entry points here. So small 4 openings with a cage which has gone through this incision.
Yeah.
Can you see the?
Yes, sir. The endoscopic.
Yeah,
also
this is a
see,
small opening. The cage has gone inside.
Yeah.
And the 4 holes.
Yes, sir.
So the advantage is that patient can be discharged today itself. So not done any major things here. With some good analgesics we can go send home.
Okay. Post-op, you take any CT immediately or?
Nothing, because X-ray is there taken, so no need to. Only for academic purpose, if you want to show how much foramen you have opened up, how much facet you have done, academic purpose we can take it. Otherwise, there is no need.
Okay, sir.
Okay. Any more questions?
7.
Anybody else wants to ask questions? I would encourage the young people to use this and ask him whatever you feel. You ask him how many cases he had to do initially, especially for the rod placement, to manipulate the rod. Like you said, you did a fasciotomy this time to introduce the rod. How frequently do you have this problem?
Definitely, the more minimal invasive you do, more problems you encounter, because its vision is not under your control. So always you are compromised. You should have a good orientation and you should have problem anticipation.
How many open procedures would you advise them to do before attempting a minimally invasive or an endoscopic procedure?
They should at least have at least done at least 40 to 50 cases of open T-lifts. so that they can understand the anatomy of the pedicle, where the pedicle is situated, how does the exiting route is related to the pedicle, so how does it exits there, what is interpedicular tissues, what all structures are there in the foramen. This all can be understood with the open surgery better. Once he done that, so he can see always in laparoscopic surgery, or they used to say that we will try laparoscopy, if it's not possible we do open surgery. Here also, what if we fail in endoscopy, what if we fail in MIS, so we need to open it. What if we do a dural injury where we need to repair, so we need to open it. So surgeon who is doing endoscopic surgery or minimal invasive surgery should also be a good open surgeon first. So I advise what is happening because of the rush nowadays, youngsters are they taking a shortcut or bypassing the routine philosophy of learning the open procedures. So we need to do open procedures only then you should undertake endoscopy. Otherwise you are lost sometime and you cannot do, then you have to call open surgeon to complete your job. So that's why I always tell be an open surgeon first, then endoscopic or minimal invasive surgeon later.
Remember that 50 TLIF, what he says is actually telling you the learning curve. So don't get dissuaded by that, you don't get upset by that, that you know I have not done. The point is that you really have to do that number of volumes to reduce your invasiveness, because that skill which you see now should not give you a false idea that we should attempt this immediately. So this is what the message he is giving, and I think that is very thing, because what we have been taught in our institution, I am sure that with other mentors also, the first thing you should be is a safe neurosurgeon. The most important thing is be a safe neurosurgeon, and then all your aggression and all is built on that safety. You really cannot do experimentation. Cadaveric dissection, cadaveric workshops like this, all can guide you, and you can slowly tend towards minimalism. Question for you, have you used one side instrumentation alone? Because see, again in literature that is there, if you read carefully, one side you do the instrumentation, because the other side the normal anatomy is there already. So one side rod and screw, the side which you are decompressing, that side you put. Have you done that, Dr. Sura?
Hello?
Yeah, one side screws. Have you done that?
No. There was a recent one publication saying that one side is enough, but
no, it's been there for quite some time actually.
Yeah.
Because in my chapter on biomechanics I had done this thing, so there is a large amount of literature which says that, but I am not convinced. And two things, I wanted to ask you another thing is, there has been a fashion in a lot of surgeons, especially neurosurgeons, they do not do a anterior fusion and they just put screws, pedicle screws, and we have done a lot of revision for those patients. The screw pull out and the implant fails, and when we go into what happened actually is that they did not do a discectomy and did not put fusion interiorly. I think you can get away with many times, but that we do it sometimes in the cervical if there is a requirement to top up or top down. You know, you go up or down to get an extra purchase. So sometimes we do that, but those patients already have enough spondylotic fusion.
I fully agree with you, because we 5 years back we did our own internal study where my colleague was doing only the pedicle screws, he was not doing interbody work. So then we compared our own results, then we have to do out of 200 patients, 10 patients we have to do a foraminoplasty for that just pedicle inserted screw patients. So always interbody work has to be done, because the chance of pedicle screw breakage, rod breakage is very high. when you don't do interbody work. So better as a neurosurgeon, we don't have a fusion concepts. Well, orthopedic surgeons have a good fusion concepts. So we should learn from them also what is ideal fusion surgery. So we learn a lot, many things from orthospine surgeons. So we should also hear to them sometimes where they do very good fusion concepts. So interbody fusion, I fully agree, it has to be done for long-term results.
But sir, prior to this interbody fusion, prior to this cage invention and all, we regularly used to do this posterolateral fusion between the transverse process, decorticate the transverse process and put a lot of bone graft gutter there. Yeah. So that had a good results earlier. Then once the industry came in, then we started putting this cages inside.
No, cage is not that costly. Nowadays Indian cages are very cheap. So the concept
No, I'm
of
just comparing with posterolateral fusion.
No. See, posterolateral fusion is a good technique, but it takes long time to fuse. It takes very long years, maybe 2 years or 3 years to have a good lateral construct. So to form that in between that 3 years, 2 years, 3 years, patient can have more problems. See, your patient, when you are operating in private, he should not come back to you. Then you should be more careful, because the failure rate is high when you do only posterolateral fusion initially. Maybe 10 years later, if both might be same, but for initial years, definitely the screw breakage is very high if you do only posterolateral fusion.
Actually, Will says posterolateral fusion. I'm only telling you because we used to do a lot of hard shell fusions.
Now
I have a large experience with that, but the amount of after years when you open it up, all those bone pieces may be there if they have not got absorbed.
The other OT, they want to tell something. Just
we'll shift.
Sir, Prakashan's want to share some information. I will hand over to Prakashan, sir.
Yeah, please. We can see you on the main screen. Hello.
Hello. Yes, sir. Can you hear me?
Yeah, we can hear you and see you too in the main screen.
So this is what we have done so far. This is the tumor. You can appreciate this tumor. This is the grasper. This is the midline. So I have taken a flap on the right side. This is a nasoseptal flap that has been taken on the right side and stored in the choana. So this has been pushed into the choana. The flap is on the left side, and after doing a maxillary antrostomy, so we have done a maxillary antrostomy here. This is the maxillary antrum. This is the stump of the sphenopalatine artery. So this is the coagulated stump of the sphenopalatine artery. And we've drilled the pterygoid wedge here. So, infection. Don't give me this foot. This is my section. No, don't give it to me foot. No, this is not. No, it's okay. So this is the stump of the sphenopalatine artery. So what we've done here is we've done a maxillary antrostomy. This is the maxillary sinus. Seen the posterior wall of the maxillary sinus by taking some bone. This periosteum is the periosteum of the sphenopalatine ganglion. Here we have coagulated the stump. Can you appreciate the stump of the sphenopalatine artery here, sir?
Yes, sir. Yes, sir.
And then now cuttle.
So left side is the maxillary antrostomy
and we can push the ganglion to give better exposure to the pterygoid.
Okay.
And then we have taken a part of the pterygoid here, so we are able to come to the lateral wall of the sphenoid sinus and the lateral extension of the tumor.
Okay.
Most of the tumor is extending onto the right side.
Yes.
This is the inferior aspect, so we need to do a little bit more work to expose the inferior aspect of the tumor here. And this is the lateral exposure on the left side. So here the tumor has completely filled the sphenoid sinus. So some of the landmarks that we are familiar with, like the opticochromatic recess and all, will not be seen at this point of time. Upcut.
How do you judge your lateral extent on?
Sir?
How do you judge your lateral extent, sir?
Lateral extension of my exposure or the
Exposure,
tumor?
exposure.
Sir, lateral extension of my exposure or lateral extension of the tumor?
Of exposure, exposure.
So, sir, the aim is to do a wide sphenoidotomy, which means we should, in this particular case, I have done a posterior ethmoidectomy on both sides.
Okay.
And I have tried to go beyond the sphenoid because one can appreciate from the scan that the tumor is completely inside the sphenoid sinus. So this is one way where I can circumferentially go around the tumor and see all around. So that is what I have tried to do.
Dr. Prakash, myself and Dr. Purushothaman, we constantly, after our we do a post-op CT.
Yes, sir.
And we always try to see, because very often, actually more often than not, I am not satisfied with the extent of my pituitary dissection. I see that, and then what I try to do is, I try to see the CT and see the thing. And what I have found is that probably we remove less bone. And Dr. Purushothaman probably has also now been helping me with going a little wider. But probably this is from the combined hybrid approach where I use the microscope and an endoscope both. But in your case, have you done post-op CT to see whether you could have gone more on the bone removal?
Sir, in our institute we do post-op CT for all patients.
Yeah.
And actually, like you said, it is an extremely good tool for assessing our own work afterwards, because it gives us an idea of how inadequate we sometimes inadequately we expose the rest of the tumor. And like you said, in my experience also, whenever I have left significant amount of tumor or whenever I think my resection has been inadequate, it has been because I have exposed tumor inadequately. So I completely agree with you, sir, completely agree with you. And that is one reason why the plan for this was a transteroid approach. So one can appreciate now the cavernous segment here. Can you see that?
Yes, yes, very well seen. Very
clear. So this is only possible if we do this extra removal of bone on this side. So in certain indications like clavicle chordomas, we can go further to expose the foramen rotundum here. So by doing that, just give me a minute. So by doing that, the entire Meckel's cave is also exposed for the surgeon. So that is the when in the anterolateral approach to the cavernous sinus, the maxillary nerve forms a good forms the anterior landmark for
Hello, Dr. Devpujari sir.
Sir, I have a question. Sir,
yeah. So I don't have a Doppler.
You have to see the mic is
I don't have a Doppler to demonstrate it, but I think now I know where the Meckel's and the ICA will be.
Hello, hello. Sir, I have a question. How to control the bleeding from the anterior and posterior intercavernous sinuses?
See, in this particular case, the tumor has come very anteriorly. So, intercavernous sinus will not be such a big problem here. But the anterior intercavernous sinus, I can assure you, is a big troublemaker and gives all surgeons a big headache. So, just a minute, drill. So there are 2 or 3 things that
we can do. The first is, say, when you're doing a tumor like a craniopharyngioma, where the intercavernous sinus is completely open and it will have to be cut and coagulated before you come into the suprasellar system. So there you can make a small nick on the anterior intercavernous sinus and inject Surgiflow first. Or you can make an incision above and below the anterior intercavernous sinus and coagulate the sinus. In both cases, you will get good control. The only thing is that sometimes the anterior intercavernous sinus can be very large. So coagulation decreases the, filling it with Surgiflow or gel foam decreases the velocity of bleed from the anterior intercavernous sinus. So when you have a planned this, the easiest thing to do is to first inject some Surgiflow and then coagulate it and cut it. On the other hand, sometimes what happens is, like it happened to me yesterday, you have bleeding coming when you are removing bone. And this is often a problem in meningiomas. Either meningiomas will block it off or the meningiomas will cause some bony hyperostosis and the sinus will open up. In that case, it's easier to inject Surgiflow and control bleeding. Inject Surgiflow and control the bleeding. So that is the thing that you can do. For the posterior intercavernous sinus, normally you will have to encounter the posterior intercavernous sinus if you are deciding to make a low dural opening, or when you are mobilizing the dura of the cellar floor and you are getting some bleeding inferiorly. Usually, if it is not in the site, in the area of your, or at least if it is not where you are planning to do dissection, you can just put a small patty or some gel foam there and then it will automatically stop after some time. On the other hand, if you are purposefully entering into it for doing a posterior clinoidectomy or something like that, then you can inject Surgiflow inside the posterior intercavernous. So this is an example of what these acromegalies do. Acromegaly often infiltrates the bone, and I wonder if you can appreciate it. There is tumor that has gone beyond the dura and it's sitting on the mucosa. So this is something which is, you can often see holes in the bone where the tumor is sitting. Grasp.
A point about these pituitary tumors, because if they ask us, that what is recurrence in a pituitary is a very, very difficult question. So probably Edward Laws or one of the few people, because what is the amount they have dissected? Are we doing actual quantification and taking an MRI immediately post-op and saying that? Because you really can't talk about it. Actually, 3 of my cases are here where we have had one, we are going to redo it because there's a high Ki 67, young male. So obviously the point is that further tumor needs to be resected, so we are subjecting him to another surgery. But this is something which you really need to know, because they comprise nearly 15% of brain tumors. So a pituitary tumor is one tumor which is going to come to each one of us. And I personally feel that I have seen very dissatisfying results with the pituitaries. Yeah, probably the natural life of these tumors is such that, we escape, vision is relieved and they're all right. But we really can't talk and we can't go to a conference and say, this is my series and these are my results, because I would like to know how many we resected first of all complete.
Sir, as of now, actually this is a very relevant point, more so because the WHO classification of pituitary tumors is also rapidly changing. So in 2017, WHO published its revised category where they removed certain categories like atypical pituitary adenomas. We have 5 high-risk tumors. We have the silent corticotropic adenomas, the plurihormonal PIT1 tumors. We have the crook cell tumors, somatotrope adenomas in males, and the densely granulated GH secreting adenomas. Of these tumors like prolactinomas in males and all, you will probably operate less often. But 2 tumors that now I encounter very often in terms of recurrence are the silent corticotrope tumors and the PIT1 pluriforminal tumors. Now, just to tell you this, the story of silent corticotrope adenomas, drill, is actually that they are aggressive tumors. You can stain for them by looking at TPIT, which is the transcription factor for corticotropes. And in silent corticotrope adenomas, they present as non-functioning tumors. They do not have any pituitary, they do not secrete cortisol. They do not secrete ACTH. They are not functioning, but on biopsy you will find TPIT positive tumors which are silent. And these silent corticotrope adenomas are aggressive compared to gonadotropes, which are the common variety of tumors. Now, since 2013-14, there have been multiple publications on the behavior of corticotrope adenomas, and one thing in common is that they are more aggressive. They tend to recur more frequently, and it is likely that in the future, tumors like silent corticotrope adenomas or the PIT1 pluriforminal tumors will end up with radiation after surgery. I mean, there is no recommendation at this point of time, Grasper. There is no recommendation at this point of time, but it is likely that in the future, the management protocol may change. This is, for example, sir, when we looked at our own publication on giant tumors, from Chitra, we published a series of giant tumors this year. So normally silent corticotropes comprise around 15% of your population in all pituitary tumors. But when we looked at our giant tumors, nearly 38% of these tumors were silent corticotropes. So there is something in their behavior which is, and also perplexing is the fact that some of these patients tend to become functioning after a few years. So you might have a period where they are non-functioning, and then the patient might present with a recurrence when they now have pituitary function. So it becomes a double-edged sword where you need to treat them for not just their size and their recurrence, but also because now they are functioning and the patient has morbidity because of Cushing syndrome. So that is a big problem.
What's your take on the intracapsular and extracapsular excision? What is
smaller tumors,
personal?
For smaller tumors, you can attempt intracapsular, completely extracapsular resection. But
is it easy to distinguish them while you are operating at these areas?
So I'll try and show if I can find the. So this is basically my exposure. I have the cavernous sinus on the right side here. Can you appreciate it?
Yes, yes.
The pituitary in the center, and I'm trying to take a little bit more bone laterally. Cuttle.
These are very common tumors, and these are normally, because although they are common, in every unit you will have one surgeon who likes them. So that has a positive aspect that his cumulative experience grows up, but it also has a negative. And the negative is that most of them do not have those tumors. Do you understand that? So when you finish your residency, you will find that you would have done nearly everything else, or at least had a few experiences with these. But you will realize that pituitary is not one which you would have, because the learning curve is much longer. That's why, if you look at it, there are actually separate articles on the learning curve.
To be 50 cases. So in his series, he saw that after 50 cases of endoscopic pituitary adenoma, his outcomes in terms of functional tumors had improved. But another important thing is regarding the intracapsular and the extracapsular dissection that you said. So, this is often a point of difficulty. Everybody tries and attempts to do a total extracapsular resection, and it looks very nice. I mean, you get it out as a ball and it looks very elegant, but it's always not easy to do because the tumors like growth hormone secreting adenomas are softer in nature, and it's often difficult to get a nice ball-like resection for them. Okay, wash. So sir, this is our exposure now. Wash. So we, sister, give me a
Very nice
curate.
exposure.
Give me a curate. Give me a curate.
It's quite very well done.
Give me a curate. Curate. So this is the inferior aspect. I have removed all the bone here anteriorly, laterally, and curate. No, sister, there is a curate that was there in my set, I think. A smaller curate I was using yesterday. Can you give that to me? This is the inferior aspect of my exposure. So the idea being that there is no part of the tumor that I am not actually seeing when I am operating. This is important, especially in functional tumors, because grasper. Can you give me that smaller curate? So another important point I would like to make is that sometimes even if you are not getting a resection of this tumor en bloc, it is still possible to do an extracapsular technique where we take out pieces of the capsules little by little after decompressing the tumor. But for larger and larger tumors it becomes difficult. I completely agree with that part. Okay, come back. Wash. Irrigation. Sister, we find that smaller curate.
In the young people, what I have noticed over the years of thing, I have seen a lot of people recovering very well. And the endocrinologist, if you have a senior endocrinologist, actually they're saying that, you will never bear children and all those things are becoming redundant. Because a lot of time you are able to save the function and improve on the function of the pituitary axis. What is your experience on that?
For what we do for... No, straight. Just to give me a note. Sir, so I'm going to start the tumor resection now. This is the exposure. We are seeing the cavernous sinus and the carotid on the right side. Here we have seen the inferior aspect where we have removed all the bone. Upcut to me. If you had a Doppler, you would have been able to actually insulate the ICA. And this is the exposure on the left side where we've gone beyond the tumor onto the posterior ethmoid here. Nice. So, ball probe.
Angled ball probe, right angle.
Right angle ball. Sir, so I will tell you what we do at Chitra. What we do is all our patients are evaluated prior for hormonal function, including the corticotrope axis and the thyrotrope axis. And in patients who have function, so the lab value there that we look for is around between 8 and 10. If the patient has normal cortisol function, we don't give steroids during surgery. But if the patient has borderline function and the endocrinologist has done a actin stimulation, then we will know what the pituitary axis is like. Otherwise, we will replace these patients with steroids for a period of 6 weeks. Scissor, upcutting scissor. We will replace these patients with steroids for a period of 6 weeks. And after that, between 4 and 6 weeks, the endocrinologist will do an actin stimulation test to evaluate his cortisol function. If the stimulation with actin gives a rise of more than 16 micrograms per deciliter, then they will stop steroid replacement. Ball probe.
For the young people, Harvey Cushing is credited with the three specialties: anesthesia, actually, neurosurgery, and obviously the entire pituitary tumor, the entire thing. Endocrinology itself, he is supposed to be the father of endocrinology also, because his contribution was so important in establishing the surgery of these tumors. So that's why the neurosurgeon has to be significantly be able to deal with these tumors, because although you take advice and input from your endocrinologist, from the ophthalmologist, but this is where probably the neurosurgeon has a very, very important role to play. And I think the future will be people only concentrate, the pituitary surgeon, neurosurgeons, those who will only do pituitary tumors, because it is so common and it is so demanding, because it's a family of tumors. It's no longer a tumor like medulloblastoma. It is a family of tumors, and each one differs in its biological profile.
Upcutting scissor. Clean. I said patients with pituitary adenomas not only have these problems, they also have a lot of other issues that you might have to deal with. For example, in young women, you will have to manage problems related to their periods and fertility. In men, you will have to manage problems regarding their libido and the ability to have a family. Well, in children, we will have to manage problems regarding their growth and especially their height. So there is really no scope for only one person managing all this. Mirror. So this is, like sir was asking, we can very selectively open the dura first, so that the capsule of the pituitary can be identified very clearly. And since the cavernous sinus on the left side is not involved, I am going to first try and remove tumor till the cavernous sinus on the left side.
See how that disc dissector, we call this a disc dissector, being so beautifully used by him, and his movements are deliberate. So study the movements. Once you study the movements of other surgeons, you will realize you slowly incorporate that skill into your own repertoire. We have to study these and learn this. It is a learnt process. In fact, we have videos of Yasarjil, and I still remember one video which really impressed me. With two bipolar forceps in his hand, he was busy peeling the arachnoid. They used to strip away the sympathetic plexus and do this with two bipolar forceps. Once you see some movement like this from another surgeon, you add that to yourself. You probably can also study the ENT surgeon, their surgical movements, and incorporate that into your repertoire.
So this is the pituitary pseudo capsule that I will open now. Can you appreciate that?
Yes.
There is a definite layer that is, which can be opened. The tumor itself, usually acromegaly will be, patients with somatotroph adenoma will have soft and creamy tumor with the consistency of white cheese or butter, grasper, biopsy. But when we follow this tumor, give me a bigger grasper. When we follow these tumors into the cavernous sinus, they change their consistency. It becomes slightly more fibrous and it becomes more vascular. So this patient has also had cabergoline, and it is probably evident to all of you but the tumor is not as soft as you would expect it to be. In acromegaly, you typically get a much softer tumor. You are getting pieces? You are getting biopsy piece? Take more, take more, take more, take more. At least this grasper is not holding. Can you give me another grasper? Yeah. So give me curate. Yeah. No, not this curate. So there is another curate.
Same like that.
Yesterday we had used it. Ring curate, no? Not this. It's a straight curate. Straight, not bayoneted. No, this is a sharp curate. I did not use this. I used a blunt curate. This is a big curate, sister. This is not the one I want. I want. Just give me my. Can you give me my mirror? It looks like this only, with a ring. This slightly bigger. So
Hello, sir. Yes. Sir, what are the points you look for, like, to identify between the tumor tissue and the normal pituitary gland?
Just a minute, sir. Just a minute. I'm just. No, sister. The useless knowledge. Are you? Can you repeat that question, sir?
How do you demarcate between the tumor tissue and the normal pituitary? How do you?
The first thing is to look for the location of the gland on the MRI.
Okay. T1 weighted.
So that is where it starts.
Okay.
Is the camera person here?
Camera payan evade?
So in this particular case, even though it was not very clear, to me it looked like the gland is sitting on the left side.
Okay.
When the tumor has involved the cavernous sinus on the right. The second thing is to look for the plane of dissection, because the gland typically tends to be yellow in color and it is not very suckable. Whereas your tumor typically tends to be soft and comes off on suction. So that is a useful way of distinguishing it.
You look for the striations on the normal, striations on the pituitary, normal gland.
Striae.
Yes, sometimes you will be able to see striae. I mean, not something that you will always be able to appreciate. If you see it, that is good.
Flat amma.
I'll try to see if I can show you the pseudocapsule here.
Sure, sir.
Because we are now coming towards the cavernous sinus on the left side.
Yes, sir.
And as we come there, we'll. So this is also not the curate I had asked for. There was a nice curate I saw yesterday. It was a small ring curate. No, this is a scoop. This is a nice ring curate, a smaller ring curate. So one more thing that you can do for quick tumor decompression is using this technique called the two suction technique, where one suction acts as a retractor and the other suction is used to decompress the tumor.
Okay.
This is a very useful technique for pituitary tumors because it gives you a lot of control on the way to dissect and remove the pituitary tumor. Correct. Come in. So, like any standard pituitary, the first step is to go inferiorly and posteriorly and make sure that you've reached all the way up to the back, to the clivus or the posterior aspect of the sella.
Okay.
That will be the first step. You're not getting it.
No.
This is the straight. No, this is not. Sister, there is
I hope all of you got the point he made. Is a very important point.
curate, sister, straight curate.
If you take off all the tumor from the front,
No, not this.
then what happens?
Curate.
That
This
the
is
diaphragm descends and comes like a veil in front of you. And you will leave a lot of residues, sometimes even posteriorly, because you will not. Then you have to do also. It is always better, as he said, to remove whatever comes, but remember that you should not allow the diaphragm to descend in front of you like a veil. Sometimes you will have to push it with a small cottonoid up and then lift the veil and again do. But all that is not necessary if you follow the principles of pituitary surgery.
నిన్న ట్రైలో ఉండింది.
Sir, should we use the lumbar drain in a pre-op period?
What? Use what?
Lumbar drain, sir.
See, I'll tell you, lumbar drain is entirely up to your discretion. So what I do currently is use lumbar drain only when I am worried about interdural dissection. That is, when I think that the tumor is invasive, it is going interdurally and I will get high pressure leak at the point during surgery. If I am not worried about that particular part, I will not put lumbar drain. So usually for pituitaries, we don't put lumbar drain routinely. But having said that, I should tell you that I used to put lumbar drain for all my pituitaries earlier. So it is really a matter of whether you're... Yes, this is what I want. Correct. So I used to put lumbar drains for all my pituitaries when I started doing the tumor. And one thing it helps in is to sometimes give you better control of the diaphragm. So what happens is sometimes, especially when you have a big tumor, the diaphragm tends to sink and come into the field very early. So you can release a little bit of CSF and that will give you, come back. That will give you a greater ability to manipulate the tumor later on. So there is no yes and no answer to that. You should definitely use a lumbar drain where you think that you will need it, especially when you are anticipating a high risk leak. The only problem of not having a lumbar drain prior to surgery is sometimes it is difficult to get a lumbar drain after the patient has had an intra-op CSF leak. And any manipulation in these patients after surgery, making them go lateral and attempting it when they are in the ICU on day 1 and day 2 increases their discomfort. So if you are planning to put a lumbar drain, I think it is easier to do it prior to the surgery. It can be done under anesthesia, it is much more comfortable, it is less painful, and it gives you an option to keep the drain for a couple of days. Also, grasper, give me some.
Sir, some surgeons also prefer to use dye to detect early CSF leak during surgery. What is your take on that?
Take some more biopsy.
Dye.
Huh?
Dye.
Sir, dye during the procedure?
Yes, sir.
Correct. Was it that will be used dye during the procedure?
Yes, sir.
I have tried doing that. It is a very uncomfortable experience because it kind of it distorts your idea of the surgical field because you are now seeing dye as soon as you are seeing CSF. So I don't use it I don't do it like that.
I think that is better for CSF rhinorrhea repair. You
Bell
put the
probe.
dye
Bell probe.
and you find out where is the rent and you bath plug that particular position. I think dye is better used for CSF rhinorrhea repairs rather than the actual tumor surgeries.
At this point, there are two papers. One is by Sirik at all. It's a complications in transsphenoidal pituitary surgery. It is mandatory reading for everybody. In fact, we probably should reread it again. CIRIC, CIRIC et al. Number 2 is the number of CSF leaks which are not picked up by us intraoperatively is quite high. It's somewhere around 25 to 30%. That means you will not see a breach of arachnoid while you are operating. I think probably that dye is for that, because the significance of these leaks are very, very high.
Sir, that paper came out of Cornell. The senior author in that paper is Dr. Ted Schwartz, and he described this entity called the grade 1 leak, where there is, so this is the gland. Can somebody appreciate the normal gland there?
Yes, yes.
This is the normal gland.
Yes.
And you can appreciate the pseudocapsule. So this was what I was talking about. So there Dr. Schwartz routinely uses dye when the patient is being positioned. So they position the patient, they do a lumbar puncture, they drain some CSF, they infiltrate dye, and then they carry on the surgical procedure. And so he described this entity called grade 0 leak, where the leak comes through the intact diaphragm. And in his estimation, the leak rate is more than 50%, even in patients who did not have any obvious CSF leak at the end of the surgical procedure. Now the only problem is that you have to be comfortable with the dye floating around in the system, because during dissection, suppose you're doing a craniopharyngioma, then everything appears to be green, and that's a very disconcerting feeling. So if you're comfortable with that scenario, it is okay, but otherwise you can also, using the dye has a double advantage, and that is that at the end of your resection, once the reconstruction is over, if there is no dye coming into the coming out, you can be assured that your reconstruction is fairly robust. So that is a dual advantage of using dye during the procedure.
I'm talking from experience. Both Dr. Ghosh, my senior colleague at Apollo, and also me, we do actually a mother-in-law, because a lot of these patients come from out of station to us, and we cannot have them afford another surgery in Apollo. So whether we see a peroperative leak or not, every patient we repair the cella floor as if there is a leak. So this is the norm, which is not there. In fact, VHS training was only if you see a leak clearly on the thing, then only repair was done, otherwise it was not done.
Correct.
But that percentage, literature if you read, there is a very high percentage of leaks which are not seen by the surgeon, and those leaks definitely should be tackled, and this would be a very, very nice way of doing it, is to make sure that after your hemostasis, you really repair the thing using glue and all the adjuncts, assuming that there can be a leak later on.
I think, Pandey sir, you have really nailed the topic. You have exactly put the point across. And what the message that everybody should take is that reconstruction is the most important part of this procedure. And if we want to give patients good outcomes, then the reconstruction has to be planned even before the resection has been planned. So, sir, in that point, I completely agree with you. I think I have come in, show this part. So this is the normal gland, which is quite yellow in color. This is a small plane of dissection here. Grasper. And at any point where you are worried that a patient might have a leak, I think there is no problem in starting with a Haddad flap, keeping thigh, fascia, fat ready, and reconstructing it as well as possible.
I would also recommend it, and which I agree with Professor Goyal, that when they talk of NOS grading and this grading and that grading, they forget that a huge amount of experience has come from the Indian centers. In fact, from CMC Vellore, because they were also doing immunohistochemistry. from VHS. We have had a very large series of pituitary tumors which we have periodically published. So publications have been from Sri Chitra, publications on pituitary have been from here. Definitely Professor Goel, especially on post-operative apoplexy, which is a very disastrous condition which all of you should be aware of and know how you can reduce the incidence of iatrogenic pituitary apoplexy, which will happen in a particular anatomical configuration of the tumor. So we also should use these grading systems and be familiar with them and not go into open anywhere else in the world and forget the important contribution done by Indians in pituitary tumor surgery. Dr. Ravi-Ramamurthi probably had about 900 plus cases, and all of them were done through the ethmospinoidal approach. That's what we all learned, and that was a lateral approach. It was something which you come from laterally and come medially, and he even till the very end he used to do that approach, and probably because he used to use that approach he did not require fluoroscopy, and he had remarkable results. We still see patients both operated by both BRM and Dr. Ravi-Ramamurthi. I have the fortune of following them up even today. So this is an important point, that work done from our country and work done, like he is doing such a remarkable surgery which is being demonstrated. This is the crux of both the World Congress which we held in Jaipur and this, that I think the Indian neurosurgery has now sort of excelled in most of the aspects of neurosurgery. Spine, as what we saw Dr. Suraj showing, I don't think there is anywhere you need to go now to learn. You can go to Indian centers and spend time, and my appeal to the other institutions is that it is not very easy for the national board residents to come and learn in many of the centers, which I find that the academic professors which hold the post have got a reluctance, and I think the younger generation should remove that, and we not only should invite all the neurosurgeons who are interested to come and learn, but also people from other countries. I think we should start doing that we offer fellowships from other countries, especially Africa and other parts of Asia and even Europe, to come and learn in Indian centers.
Clean that section. We'll start the lateral part. Bulletproof. So that is already oozing from the... Come. Show me this part. We'll start from the... No, anterior. So most of the tumor in the center has now been dissected. We have seen the gland on the left side, and we are seeing the upper part of the diaphragm also there. Now we are moving a dissection laterally and coming towards the cavernous sinus, and I am opening inferiorly in the anterior inferior compartment. And so here. So I generally avoid cutting the dura as I am closer to the ICA. I just prefer to use a ball probe to slowly open it. Oh, clean. Correct, please. Now, as we come into the cavernous sinus, the tumor becomes more fibrous, and we will also expect some venous oozing. So that is now the next phase. Come on. Direct suction to me. Bipolar, bipolar, bipolar. Bipolar. Okay, show me this one. So this is probably the inferior hypophyseal artery. Can you see that?
Yes, sir.
Oh. Scissor.
Right scissor.
Scissor. Correct. So now I am looking for the loop of the ICA here. Because we will have the horizontal segment of the ICA somewhere here as we come more laterally. One of the advantages that the endoscopic technique gives us when we are doing pituitary tumors extending into the cavernous sinus, is that it actually gives you a corridor because the tumor starts in the midline, then goes into the cavernous sinus. So the tumor creates a small corridor which you can follow. That is what I am attempting to do here. Section. What is the ICA? Correctly. Come back. Getting the loop of the ICA. Yeah. So we are now starting to see the anterior journey of the ICA there. Can you ball probe? Come back. Oh, yeah, show me the film. Okay. Correct. Sugar please, sugar please. Suction. This is okay. Once you see the horizontal segment, then hopefully we can go up into the vertical segment. Come in. Give me the curate, please. So this is the horizontal segment of the ICA.
Yes, sir.
And this is the genu, the anterior genu. The ball probe to me. Suction. Give me curate, please.
Dorsum, sir. Dorsum on the right side.
Bifilar. Give me sugar. Actually having a slightly lateral view to that. Sister, can you give me that scissor which is curved to left?
Curved to left?
It's okay. Now give me curate. Come back. We'll do a little bit more opening. Ball probe, please. Right angle. Huh? Down. Oh.
Can you ask them to...
No, do you have another right angle ball probe? Because that is an instrument I need. Extra instrument illa.
Autoclave camera. Extra illa namakku.
Correct. No, I won't. No, this side. Where my curate is?
How is the tumor, Prakash?
Sir?
Is it soft?
Huh?
How is the tumor?
प्रॉब्लम से निकल रहा है सर अच्छे से आईसी दिख गया
ऐसे दिखा
दिखाता हूँ ग्रास्पेक्टोमी ये देखिए सर, ये है किरत, ये ऐसी है.
Wall is having some amount of tumor.
ट्यूमर के अंदर है सर, ट्यूमर के ये देखिए, ये कम इन करता हूँ, ये ट्यूमर है, ये ऐसे बोल रहा हूँ.
Will you separate this?
कैसे?
Will you separate it or you leave it over?
समझ रहा हूँ क्या?
Will you separate the tumor from ICA?
धीरे धीरे करूँगा. मैं बहुत ज़्यादा मतलब I'm not trying to use force. I'm just finding the corridor. फिर उसके बाद slowly, because this is the part that will take me to the posterior compartment. The posterior compartment में यहाँ पे the 6 nerve will be located there. So यहाँ पे थोड़ा सा there is a plane available, but मैंने सोचा कि पहले anterior inferior अच्छे से clear कर लेता हूँ.
Is it towards the anterior compartment also?
कैसे?
Interior compartment, there's some tumor?
ये anterior inferior है सर, ये anterior inferior है. एक्चुअली जो राइट एंगल बॉल प्रोब था जिससे मैं डूरा ओपन करा था, वो गिर गया वो, तो वही ढूंढने, वही उसी का इंतजार कर रहे हैं हम लोग. मुझे डूरा ओपन करने में उसमें सेफ लगता है बहुत. तो यहाँ का जो आई थॉट वो लाएंगे तब तक उसके चारों तरफ वाला ट्यूमर थोड़ा थोड़ा करके निकाल दूँ. कैसे?
I don't like. It has a sharp edge inside.
कैसे?
This ring curate, I don't like.
नहीं सही, हाँ सर, मुझे भी नहीं अच्छा लगता. लेकिन
This right angle curate, this ring curate. Basically, cholesterol has a rounded one. This is a sharp one.
वो सेम प्रॉब्लम हमारा वाला है नहीं. हम आप जो कह रहे हो वही मेरे पास भी है, राउंड वाला है. लेकिन
if you are working around ICA, that will be the best.
हाँ?
They have many. You just see.
Actually sir,
They have many ring curate.
ball probe is ready. Give me section. वैसे बाकी सेल, Sister, can you get that ball probe, curate please? Sorry, ball probe please. Right angle ball probe, right? Ready. Thank you so much, sir. Come back. Come back. Curate please.
All of you appreciate the gentle way he is, breaking the tumor, dissecting the tumor. There are so many actions which you do, and the different instruments, each instrument you should learn how to use it correctly, because these ring curates can be quite a dangerous thing if it is used wrongly. We just see how gently, firmly he does that, and as far as possible he is operating under vision. So wherever he does not, there you see the angling of the ring curate, he will change. So observe these things. Then you can leapfrog over us. That is one thing which you can do. You can be much faster and more this thing only when you have done enough. There are certain parts of surgery you can run, and there are certain parts of surgery you should never be fast. And so that is being very well shown by him, that these are the things which you should do at a particular optimal speed only. You should not try to be aggressive.
So this is, I am at a point where I am trying to delineate the loop of the ICA.
Yes.
And because of the fact that she is probably taken cabacolin, the tumor is quite fibrous. So if it was a soft tumor, this exercise would have been much easier. But so these two sections are very helpful. So this is the loop that is going like this. And like I had pointed out earlier, the ICA loop is a little tortuous in this particular patient. So there is, while the loop on the right, on the left side is quite straight, this is a little loopy. It is looping a little medially and then going back into the, towards the dural ring. Correct to me? Correct to me? Can you give me a ball? Correct, same. Grasper. Ball proof. Come back. Correct. Tumor which is inside the cavernous sinus here is quite fibrous actually. And one of the things that we must remember is once we enter into the lateral compartment, the cranial nerves are no longer covered with arachnoid, so they lie in direct contact with the tumor. And one reason you should be extremely gingery when you are dissecting these tumors is because once you cause cranial nerve palsy by direct trauma, it's often irreversible. So the cavernous sinus is divided into four compartments by the ICA, and the superior compartment lies above the horizontal segment of the ICA. It contains the third nerve which lies in the roof of the ICA. Bipolar. While the inferior hypophyseal artery is directed medially, the inferior lateral trunk is directed laterally. So that is another. So the other ones, curve to left. Scissor curve to left. Upward is also. Correct. Actually, the ICA wall is not nicely coming. That is. The ball probe. Fibrous, no? Sir? This is quite fibrous. Come in. Blood. Show me this position. On. Irrigation.
What is the use of your frozen section at Sri Chitra? Because I actually really appreciate my senior colleague Dr. Ghosh. What he says is even for an ordinary meningioma or everything a frozen is sent. What he says is you're building experience for the pathologists, because as their usability also increases. So do you routinely use a frozen section when you are doing your pituitary tumors?
So pituitary is not so much, sir, unless you are in doubt that it is some other tumor, not routinely. But we have a pathologist always on standby if we want to send frozen. And whenever we are in doubt, we send it. Not for all pituitaries, but occasionally, yes, sir. For example, last week I had a patient who had a germ cell tumor. So we had a 10-year-old, 12-year-old patient with a lesion which did not look very classically like a pituitary. And considering the age and the other things, we biopsied, we found germ cell and we stopped. So that is a very important. On the other hand, if the patient has got a picture which is, now we are going in a lateral compartment.
Yes.
And this is where we normally will not extend our dissection to for non-functioning tumors. Even for functioning tumors, it has to be done completely being aware of the fact that we can give this patient a third nerve palsy, sixth nerve palsy. It is done very carefully. So not all patients are candidates for dissection of the lateral compartment. In fact, for acromegaly with a small lateral compartment residue, gamma knife has got good. Here is actually a little softer. The tumor around the ICA was a little fibrous, but the tumor here is a little softer. So, come back. So, can somebody appreciate a nerve there? Can you see the nerve between my... This is probably a third nerve.
Yes, sir.
Lying in the roof of the cavernous sinus. If we had electrophysiology, we would be able to insunate the third nerve by stimulus. Wash for me.
Warm saline, please.
Just clean your scope. Clean your scope.
Change or clean?
Clean. ठीक लग रहा है ना
We plan to dissect the IC valve. Do you plan to dissect the IC valve? No. Actually, mic.
Just plan to clean. No, there is something sitting there. Something sitting on the clean.
Hello, Dr. Pandey. Hello?
Yeah, we are hearing you. Tell me, Professor.
Actually, I also have experience that the part of tumor which is present in the cavernous sinus becomes fibrous because cavernous sinus itself has a lot of tuberculation.
Yes.
And the tumor is filled in the tuberculation.
Okay.
So that tuberculations make the tumor consistency fibrous and sometimes difficult to remove. This becomes more important in cases of acromegaly.
How do you tackle that? surgically, with your surgical maneuver, what is your way of doing it?
Part of tumor that comes spontaneously in section that can be taken.
No, you're not clear. The voice, I think mic you have to hold.
Yeah.
Yeah,
Actually,
now you're okay.
Is it okay?
Yeah, it's fine.
So what we do, just like what Prakash is doing, you suck whatever tumor comes in the suction itself by gentle dissection. It should be taken out, but it should not make very vigorous attempt to remove the tumor. Otherwise, it will lead to cranial palsy.
Anybody uses a CUSA here?
No. No.
Sir, I would be very Sir, actually in a tight space, one more problem is that CUSA generates heat also. So you can also cause neuropathy by direct thermal injury, plus the dissection space is quite tight. So scissor, come back, scissor. For meningiomas, it's much more convenient. For pituitaries, it's not so much, sir.
Consistency wise, probably they are ideal tumors. So probably we are waiting for a little development, because a lot of these things, what we remove the ring curate, probably if it is a very fine CUSA tip which does not generate too much heat, maybe.
Sir?
It may be, I mean, as the instrumentation develops, because of the consistency. Some of these tumors, but these probably also come out easily with the ring curates.
You want to technical increase, as the technicality increases, we will get a small CUSA which can be used.
Yes. Irrigation. Irrigation.
114.
For all of you, any instrumentation which you missed here, which you feel we should acquire, tell us that, so that we can add that to the surgical armamentarium.
Certainly, sir, certainly. Come back. Correct. So can you give me my mirror dissector?
30 and go, sir. 30 and go, so that we can see the lateral part.
Hold the 30, because what will happen is it will go across, no? Give me 2 minutes, let me just see if I can find this wall. Okay. I was actually trying to look for the superior compartment. No. Go around the horizontal segment and see the superior compartment.
Got it.
So some of this must be a scar from the last surgery also. So now there is tumor in the posterior compartment. That is what I am trying to access. But I am not very sure of where the tumor is. Correct, please. What's the dura there? What's the dura there? What's the clival dura? So there the resection is good.
Lunch is ready. I think all of you who are hungry, you can go there, because we'll do it in turn so that we can continue to be here also. Those who are hungry can also go ahead with the lunch and then come back and join. And also I would request all of you to
come for the dinner too today at the Crown Plaza. Don't miss it, please.
Section. Grasp to me. The thing is gland, sir. Two more. Yellow one. That one. Two more. This one. Two more. That is tumor. That one is. No, that's that pseudo capsule. No, you can find the capsule there. Grasping with this thing. No? So one can appreciate the gland here. This is the normal gland on the left side. Which gland is it? This is the gland. Sir is asking superior. The overall brain cap is there.
This patient was appeared on the right side?
Right side. Sister, there is a black grasper, no? Can you give me that? Yes. Yes. Superior, left side. No, that is a black grasper in the side.
First black color tandale grasper.
Give me the suction. No, this one, correct. Come in. Your normal gland, sir, or no, you're plain against the normal gland. This is the normal pseudocapsule. This is the gland tumor and pseudocapsule. So can you see that gland which is very nice and yellow orange in color and doesn't come in the suction in the same manner? This is the small pseudocapsule that you can slowly peel away.
Yes,
the
sir, we can
capsule
appreciate,
that you can slowly peel away from the.
Sir, does our tumor resection strategy depends upon the type of tumor, which hormone it is secreting? Between the growth hormone secreting or ACTH?
No, I didn't catch your question. Can you please ask me that question again?
Sir, is there any change in the tumor resection strategy between the tumor which is secreting growth hormone rather ACTH, sir?
You mean the technique of dissection?
Extent of resection, sir.
Extensive. This is a good question actually.
Yes,
so, in terms of non-functioning pituitary adenomas, the aim of the procedure is to take out the tumor completely without giving the patient any new deficits. So that is the main aim of the procedure. And so in a patient with non-functioning tumors, the first indication probably for surgery would be visual dysfunction. So for tumors that extend into the cavernous sinus, you would normally not decide to resect that part because you can give this patient an extraocular palsy. And the general statistics is for cavernous sinus residues, the rate of progression is around 15%. For intradural residues, the rate of progression is around 30%. So that is on an average the percentage of people who will require some treatment after having a good resection with a small amount of residue in the cavernous sinus, 15%. So can you see this? This is the normal gland. This is the edge of the diaphragm. This is the diaphragm here. And that would be suction. That would be our surgical aim. Would be good decompression, would be adequate removal of the tumor in the cella, the supercellular system, chiasmal decompression without giving this patient a new extraocular palsy. For functioning tumors, now the aim of resection would be much more radical. You would want more aggressive resection. Keeping in mind the fact that there are certain limits to aggressive resection. Keeping in mind that you don't want problems like extraocular palsy or IC injury during the procedure. So to cut it in short, whether you will explore the cavernous sinus in all patients, no. But in functioning tumors, yes. And in functioning tumors also, the cavernous sinus exploration can be graded in the sense that the anterior-inferior compartment does not have any cranial nerves. The anterior-inferior compartment is this compartment that lies anterior to the ICA, inferior to the horizontal segment of the ICA. Got on this comment? Ballproof. So here there are no cranial nerves. Here you can resect tumor in this compartment without worrying about extraocular palsy. However, in the posterior compartment you have the sixth nerve, the superior compartment you have the third nerve. So there you have to be much more careful, and if you plan this, you should also you should counsel the patient that these problems can happen after surgery. So there is another important thing that is now being discussed in the surgical technique, and that is resection of the middle wall of the cavernous sinus. So in the last 5 to 7 years there has been evidence that even in patients who do not have NOF for tumors, the cavernous sinus wall might be infiltrated by functioning tumors. And this has a lot of relevance because this can result in long-term both recurrence and incidences where remission has not been achieved after surgery. So in those patients, especially NOF2 and NOF3 tumors, in cases like acromegaly, there is also an indication to resect the middle wall of the cavernous sinus.
Sir, I have one question. During your initial days with fibrous cellular tumor with cavernous extension, how did you identify the ICA and start detecting it out? Since now, in this case, you are making it very easy by detecting ICA. How did you start, and what are the ways you did to identify ICA, and how you started detecting lesion from ICA?
Sorry sir, am I audible sir?
Sir, one question is there. Sir, can you hear us?
Application. Ball pro. Oh, sorry, mirror. Come back. Come back. Section.
Sir, am I audible sir?
This is the superior compartment. Now we have entered into the superior compartment of the cavernous sinus.
Sir, can you hear us?
This is the superior compartment of the cavernous sinus. This lies above the horizontal segment of the ICA. This is the horizontal segment.
Sir, there is a question, sir. Can you hear us?
30.
He's asking whether can you
Hold on.
Hello? Hello, yes.
Sir, can you hear us, sir?
Yes, please go ahead.
Okay, sir.
Sir, one thing sir, for a fibrous cellular SOL extending into a cavernous with
Your
cavernous extension.
voice has become a little weak.
Sir, am I audible?
Yes, now it's okay.
Sir, for a cellular SOL with cavernous extension, being a fibrous lesion, how during your initial days of practice, how did you identify ICA, because it's completely encasing ICA, and how did you identify ICA and during your evaluation during these periods of identifying ICA?
So in this case I am going by purely visual this, and by anatomical, to have a Doppler it would be the best case scenario.
Okay, sir.
I don't have one right now, but I am going by purely anatomical localization. So this cavernous sinus dissection is ideally carried out when you have good Doppler and section. So just give me the curate. Curate. Just if I can show them the wall of the IC. Come here.
In sir.
Show the wall. What is it? So this is the vertical segment of the IC. Can you see that?
Yes, sir, we can see.
The IC is coming like this, and then this is the horizontal segment here, and we have superior compartment on top, and this is the ICA looping like this. So this is the loop of the ICA. In a patient who has not had a prior procedure, it is much more evident, because then you can take out the soft tissue more aggressively. Here it's being done Favorite? Section. Let them go. Okay. Sorry. Great.
Sir, during the manipulation of ICA, are there chances of vasospasm or post-operative ischemia, stroke?
Okay, not with the large segment of ICA, sir. Not with the cavernous ICA, never had that problem. It can happen to the smaller, in patients with subarachnoid hemorrhage, smaller, medium-sized vessels like MCA and ACA, but...
So, do we use papaverine after the procedure, sir?
Angle section. Correct. Posterior part you are trying to. No, this is gland, no? Section. This you're asking, no? This is clear, no? This is gland, the gland and diaphragm. No, not remove that. No, anterior. This is gland. This is normal entire gland, healthy gland. This is cavernous sinus, this is cellar, this is ICA. I really think we've reached the limits of our resection here. Now, I have not seen the posterior compartment, that is the only thing. Just wondering, there must be a plane somewhere. बराबर करो
बराबर
irrigation. Curatorial. क्या कहते हो बंद किया जाए वॉश ओके हाँ so I think we've reached this is the final part of my resection. This is the one can appreciate the yellow gland on this side, the diaphragm here.
Yes, sir. We can very well appreciate, sir.
This is the gland. Since we're using a 30-degree scope, we're looking up. And correct. So this is the gland on the left side. This is the diaphragm. Can you appreciate the diaphragm?
Yes, sir. Yes, sir. We can appreciate.
Now this patient does not have a very large extension into the suprasellar system, which is why we don't have a large diaphragmatic descent. There is no this is the nice yellow plane that was available. This is the edge of the diaphragm. One can appreciate the ligament here which forms the edge of the diaphragm. This is the superior compartment of the cavernous sinus. I have extended my dissection into this space above the ICA, and this is probably because of a prior surgical procedure or for the tumor characteristic itself. This is the roof of the diaphragm, roof of the cavernous sinus. This is the ICA loop. I think you can appreciate the ICA pulsations. Can you see that?
Yes, sir. Yes, sir. We can see it, sir.
And I'm not, I don't think I can extend my resection any further. I've taken my dissection. This is the anterior inferior compartment, this one here. So this is the compartment which is safe to dissect because this lies below the cavernous segment of the IC, anterior and inferior to that. This does not contain any cranial nerves. And this is the lateral compartment of the cavernous sinus here, which contains the third, the fourth and the sixth nerve. So when we do a postoperative CT, you will have tumor in the lateral compartment and the posterior compartment, and that will have to be dealt with by radiosurgery. This is the, show me this side. Show me this side. So that is the, wash. Sister, can you get me some hydrogen peroxide? So no, take hydrogen peroxide. Take 1 drop in 10 ml. 1 drop, just 1 drop. Okay.
Can I switch to 0, sir? Switch to 0?
Yeah, just
you are comfortable with this?
Yeah.
Okay.
You've taken fat, no?
No, fat is ready.
So this is just to give you an illustration of how lateral our exposure is. So Cortil. This is the midline. This is the midline. And the tumor extends all the way to the anterior aspect of the sphenoid sinus. This is the sphenopalatine artery here. And the dural opening has been extended almost all the way here. So this is the ganglion, and this is the lateral wall of the cavernous sinus. Wash.
Warm saline, sister, warm saline. Please change to warm saline. Use saline first, warm saline.
Even normal saline? This is without peroxide, no?
Without peroxide.
Just ask BP.
BP?
Pre-induction was how much? Saline, no?
Sisha kodaga mumpu etra? Induction mumpu. Appa etra?
How different between the 0 and the 30, no?
Yes, very much. Focus is also so much different. Immediately we put the 30 scenario completely.
It's not comfortable operating in the 30. The only thing is that irrigation. Fat, please. Close, no?
Fat.
Surgical to me, surgical to me.
Surgical.
First surgical.
Irrigation.
Discharge.
Give me surgical, please.
She went to get it.
It will take surgical.
She didn't take it. Surgical cuts strategy into 4 or 5.
Come on.
Okay, sir is ready, sir.
Surgical.
No problem, sir. If any people let me
Hmm?
know, we can arrange something.
क्या सर?
Phone.
नहीं आपने कुछ बोला सर? तो ठीक क्लोज करूँ? सर्जिकल प्लीज. हाँ क्या सर? एक्चुअली इसमें इस स्कोप में ग्रास पर
कुछ बोल रहा था सर.
So I am placing some surgical in the salon for hemostasis. Fat, please.
Surgical wrap, sir. Only piece.
Big fat.
There was no obvious leak, right? No. Sir is asking about leak. Sir is asking about leak.
नहीं सर कुछ नहीं.
Sir. Did you see BDN in this? No.
नहीं ग्लू नहीं डालेंगे सर. ग्लू नहीं डालेंगे इसमें.
BDN. V2 difference in VDN and V2. VDN nerve and V2.
VDN में डिसेक्ट नहीं किया सर क्योंकि इसमें ना बहुत ज़्यादा बड़ा lateral recess is not there. So I just did the sphenopalatine and the this thing and the pterygoid wedge to get exposure left.
Only ICA, cavernous ICA.
हाँ सर.
Exploration of posterior quad axial is enough.
समझ क्या सर?
If you want to explore only cavernous ICA, so if you open only the posterior quad axial, that is good enough.
हाँ. Grass
cavernous ICA is present in the thorax. cavernous sinus is the lateral wall of the lateral sphenoid sinus wall. That is good. थोड़ा सा नीचे लोअर कर दीजिए आप जो है स्फेनॉइड साइनस सेंट्रल वाल क्यों भाई?
नहीं सर सही है, मतलब इसमें क्योंकि वो इसमें एक्चुअली ट्यूमर और इतना फाइब्रस था, हार्ड था, इसीलिए मतलब इतना आई थिंक इफ इट हैज बीन सॉफ्टर क्लियरेंस पोस्टीरियरली और हो जाता है.
बट ठीक है,
बट section. Can you give me one tattoo?
Can I clean the scope, sir? Clean. Base में. Clean कर दो सर. Clean कर दो.
Okay.
Clean कर दो. Clean.
Okay.
Neurosurgical count okay? IT count okay?
Come back. Tattoo. Come back. Okay.
Gel form.
Button you can put the gel form and clean the
coin. Thank you, sir.
Okay, thank you. Thank you so much, sister. Thank you so much. No, she will require some radiosurgery because the
Yes,
triangle
sir,
in the
we-
back, no?
Actually, sir, we sent the patient for radio surgery only. Yes, sir, that is fibrous within the trabecula of the cavernous.
No, Mike. So, is there anybody in auditorium? Are you able to hear me?
Yeah, I think there are a few of us here.
So, I
Rest
think
have gone
this
for
is
lunch.
the last case for this workshop now. So, this patient is a this is a 39-year-old male. So, operated for pituitary adenoma earlier. We are operating for the residual tumor. You can see here this. You can see here this is the tumor.
Yeah.
Basically, the clivus, the tumor has eroded the clivus and gone down. You can see here this is the anterior wall. This is the anterior wall of the
Sphenoid sinus, yeah.
No, this is cellular floor.
Okay.
Cellular floor. Basically, the cellular floor becomes like this. This is the clivus. And this part of the bone is intact. You can see here, even the tuberculum is also very thick.
Yeah.
So basically, there is large part of tumor and very little supracellular component.
Yeah.
Okay?
Yeah.
If you see here in the CT, just show the CT. You can see here this is part of bone anterior cellular wall basically.
Yeah.
So this is quite thick. So we have to drill it till the tuberculum. We have to drill here the lower part.
Yeah.
Go laterally and take out the tumor.
Sure.
You can see here the evidence of the previous surgery. You can see here there is posterior septectomy here has been made.
Yeah.
Okay.
Yeah.
So let us see. Any question?
No, as of now.
So basically this tumor is a because it's a redo case, and I expect there might be some small opening in the anterior cellular wall basically. So we have to identify it, and in all these surgeries basically the exposure is the key. So 90% time of the surgery goes towards the exposure, and the tumor removal is only 10%.
True.
If you compromise with exposure, so the outcome will not be good.
Yeah.
So you spend a lot of time in exposure, so the tumor removal becomes very easy.
Sure.
Okay.
What is happening on the other side? Mangal. Huh? Closure over.
Mani sir?
Yeah.
So the IK67 index patient is just induced. They are about to start in another 5 minutes.
Okay.
They are taking the graft, fat graft, and the patient has been positioned and painted red. They are taking the fat graft. Another 5 minutes, Dr. Jaiswal will start endonasal transmural surgery, sir.
Okay.
Okay.
This is a patient I had operated along with Dr. Purushothaman.
Yes, sir. Yes, sir.
And yeah, Krishna, you were also there.
Yes, sir.
So this is one of the typical cases where I always had this thing there, but we did adequate bone removal, but then the post-op CT, the bone window shows that yeah, we should have probably done more of a resection, but because it was a liquidy tumor and it came out easily, I think in this patient, Krishna, will remember we tried Valsalo also, and we did not get much of a tumor coming through, and that is a period of time we stopped. Which one? Oh. Huge place, right? It has a nursing college, it has a dental college, it has diabetology, everything it has. I am hoping and I am working towards making it a first university medical college. It has everything. The renal transplants were started here. Dr. Mani, the nephrologist, was here. Dr. Badrinath was here, the eye department. Child Trust Hospital was here. They have all moved out of VHS, sadly. But each of those people were students of Professor Sanjeevi. In fact, Badrinath left twice, and then Dr. Sanjeevi called him back again. Then he eventually left. And they have founded institutions. So you talk about the speciality. So nephrology it had. Pediatrics it was. Ophthalmology obviously it was. Both Udi and Sankar Netralaya have their origins here. And the massive blood bank which you see, which any tumor you can operate here with no worry, you can manage. It's only after CMC Vellore, this is the only other place which has got a hemophiliac center. So the Revati Raj is actually here. She is the hematologist here. They not missed the bus, probably it is the time. So there's a phasing. I am really hoping it's a phasing, passing phase, and it goes back to its original stature. They had lab services training. They had they still have a nursing college. They had a dental college which moved out.
Big sister. Theater. Big sister.
She for the theatre.
Yes.
Right, Osman. Ibrahim
Divider drill.
Divided.
I was trying hard to bully my anesthetist, and I wanted Dr. Purushothaman and me, I thought we would show you our usual high rate, partly endoscopic and then this, but the lady has already eaten and they are telling me a lot of reluctance there for the endoscope. So anyway, I would have been happy to do one more case, but it's already going to be 2:45 and everybody is tired probably. Dr. Jaiswal, yes sir. Any instrument you felt that we did not have which you would have liked to have? I myself don't have many instruments. I don't have Doppler, I don't have microneurology. I think you have more than me. Anyway, you have all instruments. Yes. I don't think you require, except you need to have a Doppler, I think. Okay. And if you have navigation, it will be good. Yeah, that is coming. That will be sooner or later it will be there. We are planning a change of both our microscopes and navigation in both sides. I am seeing whether I can get the robot. Especially the Globus robot is what we are eyeing. But let us see, there are a lot of slips between the cup and the lip. But with God's grace, the many gods we have, we hope that the next time you come, you will see it state of the art. On. Light. Straight. Yeah, it's okay. Mahesh, the rascal app 30 degrees is not working, no?
Hello sir, currently 30 degree not working sir.
That
Side not working sir.
Not working, huh?
Yes sir.
No light at all?
No light. No display only.
Okay. Make sure that is kept and you will return it immediately.
I want to MC sir.
Okay. It's okay, thank you. Can you keep it totally down? Yeah. Down, more down. Dr. Pandey, can you see we are keeping the table down so that we can operate like this, not like this. Yeah, we can see it. So this is very important, becomes important when you are operating long cases like some cardioma. Do you tilt the head towards your side? Yeah, some. Yes. Because I have noticed that the ENT surgeons just prefer to keep it straight. They don't like tilting it, but we are used to our transfenoidal approach, so we always like the patient facing us with a tilt towards the surgeon. Yeah, to save our neck, as Dr. Selvapandan says. Light off.
Top lights off.
बढ़िया भी बड़ा है।
बहुत अच्छा लगा सर मुझे।
ये बड़ा है क्या कि मिलता है?
ये डिस्पोजेबल मिलता है।
अच्छा एकदम भाई लाया यहाँ आ रहा है।
इसमें बाइपोलर डाल के सब डाल दो मेरे पास।
You can make it by six or
देसी बना सकते।
देसी बना जीवन में हम गए।
Section.
Now endoscope holder देसी वाला जो पेटेंट करने के बाद दिखाई
नहीं बढ़िया लेटरल अच्छा लगता है वो. So right now I am in right side of the nose. You can see here. This is middle terminate. This is inferior. I think. Okay. We are able to see some synechia, I think. Okay, do you have mono? No, idiot. Colorado ले लो यार. तब तक हमें बात कर दीजिए. हाँ.
So these are the things which happen to your nose after the ENT and the neurosurgeon have come once.
Here, I'll take. Okay. Get it sorted and that ADR. Yeah.
In your practice, do you give these people with a very aggressive pituitary after resection, do you send them for radiation?
Sorry?
Do you send them for radiation, especially these aggressive?
Yes. Radiation, gamma knife, we have a lot of adjunct.
Yeah. Because I am planning to do this, he is a young policeman.
Yes, actually.
So, vision improves, so now we try to get the maximum for safely out and probably subject him to this thing because this high Ka67, I have had 3 cases, this is the 3rd case. And the other 2 recovered very fast. They recovered within about 9 months. I am not so sure about the exact thing, but they recovered very early. And the recurrence can be very large.
The classification of pituitary is also changed a lot.
Yes.
No, small, large one.
It was already very complex, now it is becoming even more so.
No, there are a lot of markers have come.
Yes.
But still many people are not doing it. Even in my center, they are just in process of starting it. So it makes your prognostication and
actually earlier when my thesis, was on the immunohistochemistry of pituitary tumors, so that this was my thesis there. And at that point of time, All India Institute was doing that and a little bit in CMC Vellore, but mostly we were the ones who were chasing this immunohistochemistry and correlation. But it was flawed because we were getting, it's a surgical bias, no? We get only large tumors which are macroadenomas, so probably it does not really sample the real size. But that time itself the tumor biology and pathology was quite complex.
Actually all these markers are also being done only by ISCs.
Yes.
There is no special technique required for and IC is being done in many centers.
Yes.
But somehow people have not started doing it. But if you see in Nivas, in CMC Vellore, in Srichitra, they are doing this. I think the management of pituitary has also changed a lot with development of endoscope, development of these markers,
Actually, you may not be aware that when NIMHANS was started, again Dr. Ramamurthi was one of the main advisors both in the starting of All India Institute and in NIMHANS. And we had an MOU with NIMHANS long ago. So one of our specimen always goes to NIMHANS because that was a request by them at that time that large centers like ours had to support their brain tumor formulation. So that is why over the years, for more than I think now 25 or 30 years, a sample has also been going to NIMHANS. So we have those parameters, and our histopathologist, that is the pathologist here, earlier Dr. Sarasabharti, and later, so they are all actually Dr. Mitra Ghosh also, who is at Vanagram, does some of our immunohistochemistry and pathology. So it's available, I know, but the point is that it's rather complex and the whole battery becomes quite expensive for a patient.
Yes, I agree, but unless you know what a tumor is, the further management is not possible.
I know.
So for that you have to know what is the type of a tumor you are dealing with. And NIMHANS has a very rich tumor bank, brain bank. You can see here, this is the part of the septum which was removed. Are you able to see, Dr. Pandey?
Yeah, yes.
In the center?
Yes.
So first I am decongesting it. What is the BP?
BP?
Okay, thank you. So I think anesthesia faculty here really, they need a special applause. And you people are very lucky to have this type of your good colleagues. We always support you. Otherwise everybody knows what happened between the surgeons.
Don't ask their opinion about Dr. Pandey, they will have a real bad opinion of Anil Pandey. But we normally are a very good team, definitely.
But I think if you want to improve your department, you have to have very good relation with them. And the first lesson you can make, always put their name in your publication and send a copy to them.
Actually, all my presentations, not only all my presentation, all of Dr. Ramamurthi, the department have all of us as co-authors. That has been a culture which I am continuing, but it is a very nice thing to do, and that is something which we all should actually do. We should never, belittle the contributions of our neuroanesthetist and all supporting staff.
Yes, neuroanaesthetist, radiologist, pathologist. And let me tell you, if you do so, your life, you will live in a luxury. This is middle terminate, which is opposite side middle terminate. I think this is the opposite side middle terminate, okay? This is come here. Dissector. This is after do the open. Big one. Yes, bigger one. So you see here, the first thing is inferior terminate. Okay?
Yes.
Are you able to see inferior terminate?
Yes, we.
It's already very much lateralized, so but still to make some more space, I will lateralize a little more. So first infracture, like this. and then out fracture. So this is the coena, this is the posterior septectomy which has been done, I think. This is the remnant of the middle trabinate at the left side, okay? Are you able to see?
Yes, we can.
Mono. You can see here it has made Synechia formation with the septum. So I am first breaking the septum. I have removed the Synechia. Okay. Resector. So I have lateralized it. Now right side. This is the inferior trabinate. So first I make it in fracture. Then out fracture. And this is, I think, this is the middle. I don't know, this is polyp, probably. This is the middle trabinate of the same side, this is middle trabinate probably, I am not sure. It is hanging through the, when it has come to this same side. However, this is again some Synechia, so I will remove it. No. So I put this trabinate in the coena. I think it will come in my way, so I will take it out. Dr. Pandey, do you have some ENT colleagues also here in the auditorium? No. Do you have a scissor? Yes, thank you. नीचे कर देते हैं ऐसे बताते हैं मुनो मुनो मुनो
Nice divider, I think. Huh? अगर कोलोरेडो ना होता तो मुझे बहुत मुश्किल होता है इसमें प्रकाश बोले थे कोलोरेडो ला देना मन पानी मोनो वैसी नहीं बायोप्सी और सिर्फ थोड़ा सा रखते हैं मोनो 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 Berarti just give me please. Berarti लगा कहीं तो Come on. Battery. Please take it. Keep it. Keep it. So I have taken out middle trabeculae of the same side. It was hanging and coming in the way. Right. Oh. Granite.
So this is the, I think, small opening which was made probably, but I will make it wider. This is superior turbinate, okay?
Yes, sir.
This is appears to be superior turbinate, so I will cut it. Basically, this approach is known as cavity and half approach. You have to expose the sphenoid sinus as a cavity and posterior thoracic as a half on both sides. So we have removed the superior turbinate. That's it. This is mucosa of the posterior thoracic cell. Do we have one more? Similar. Yes, yes. Thank you, madam. God bless you. I think this is polyp. Can you see, Dr.
Yes, sir. You can see.
Pandey?
We can see, sir. Yes, sir.
Debrider, do you have debrider? I try to debrider. Debrider is कहते हैं वही यार. Debrider का वो किधर है? Debrider मतलब जैसे जीप चाटता है ना, ऐसे चाटता है बराबर चलता करता है पूरे. इधर ही किधर किधर है हमें दो yes okay thank you बहुत गए तुम्हें डिटेक्टर डिवाइडर जैसे एक बार मर्सिडीज चला लो उसके बाद फिर मार्टिन बैठने मन नहीं करेगा उससे भी फील्ड डिवाइडर इनवर्ट लाइट इधर इंस्ट्रूमेंट इधर नहीं इसमें चेन्नई का इधर लाते हैं लेकिन इंडिया लोग थोड़ा नहीं चलते इतना हमारा यहाँ चल रहा है ना बोलो ये बहुत फास्ट चल रहा है ये आई थिंक मेट्रोनिक होगा इंटीरियर पर स्ट्राइकर का है चलो इस पर चलते हैं निकालो I think this is split update of this side, left side. Are you able to see, Dr. Pandey?
It's very clear.
Okay, this is split update. Detector.
Have you people bought the exoscope at SGPGI?
Not yet. Exoscope is a very good tool, particularly for superficial lesions, but not for deep-seated. It's not nice for me. It's not for Can hold? No problem. एक हाथ पानी दे दो डॉक्टर को देखो जिंदगी में हाँ आपको मर्जी है बैठे हुए यहाँ पर सुनो प्रकाश कहाँ जाओगे यार घंटे में जाएगा मैं क्या हूँ प्रकाश अरे बैठो कहाँ जाओगे वहाँ पर हमारा साथ दो हाँ करो बैठो कहाँ जाओगे वहाँ पर हाँ काफी अरे काफी बनाएंगे यार ये कृष्णा हाँ काफी हो जाए यार ये तक तुम है ना निकाल देंगे उसको हाँ बेटा हाँ ये तो निकाल देता मैं ये तो ये तो
This is superior turbinate, okay?
Yeah.
Opposite side, left side. Defibrillator. इसका नंबर थोड़ा कम है. हाँ जो अंदर ये हाँ देख कर चल उल्टा उल्टा सा उल्टा करो. ये आवाज निकलता है. कोई चच्चू निकालते हैं.
This is an older debrider. They palmed us. Actually, I wanted a debrider, but they said you have this budget and all. He pushed this on us. I've been trying to get him to give us the next version of this.
Even this is also very good. Not so bad. Munu. This Colorado needle has made our life very simple.
Okay.
This cost only 2,500 rupees, made up Stryker company. Very good. I recommend everybody who does the pituitary surgery to have this.
No, we'll get it for us. This is what I was asking you. Anything else you would recommend, we tell that we will get that.
Manu. So I am removing some more part of septum upper part. Battery. Manu. These are the cases where navigation appears really benefit.
Yeah, definitely.
कैसी नहीं रिफ्लेक्ट नहीं है, दिस इज प्रोस्टेटेक्टोमी. बैठती वो दे दो डिवाइडर अभी लिख कर देंगे हम. अंदर जाता है तब दबाते हैं पहले, नहीं रास्ते में खाने पीने लगेगा वो.
How do you train your residents in this narrow area of neurosurgery?
They do exposure. Actually, this is learning curve very high, so I have to hold their hands, then tell them.
Yes, yes.
But I am very happy. Most of them think they are doing good job.
How did you learn?
I think Dr. Krishna is also doing good job.
How did you learn?
I learned by learning and doing.
No, but was it anybody you spent time with, or anybody who?
Actually, my learning curve was more that because I learned myself. I could not do, unfortunately, any training somewhere.
Yes.
But I think in 2000, before COVID, I went to Pittsburgh.
Okay.
For basic course.
How was the course there?
The course was good. The course was good. They take 30 candidates all over from globe. They first ask for their CV, then they evaluate themselves whether the candidate is good or not. And once they choose it, then only they give you the signal that now you can go and get the registration done.
Okay.
So the course was good. It's really good course if somebody want to do it. But I advise that if somebody is really interested in India, there is a lot of patients overload. He should work with somebody, learn it some, then only after go for these courses. Otherwise it will not be good. But see.
The course they have cadaver or simulation models?
They have cadaveric course. Actually it's about 4-day course where they live surgery, cadaver, hands-on dissection, lectures, everything. It's a very dedicated course. This is an interdisciplinary sector. Dr. Pandey.
Yeah, we are seeing that.
We are actually inside the spinal sinus. This is inside the spinal sinus. This sector was left untouched. If you remove this, probably tumor will be removed.
Okay.
So because it was not removed, so that's why it was incomplete excision, I think. Just hold on. मैं दिखाना चाहता हूँ लेकिन उसमें है नहीं. हाँ बैठ और मोटा दीजिए, इतना मोटा है. थैंक यू.
How was it before and after the course? What are the ways that course changed your surgical practice?
Actually, I did cadaver dissection. I had more confidence. Then after I started doing cadaver science work, and I think my experience of excision and surgery precision improved more after the course. Because you see, unless you see it, you don't believe it. You don't believe it, you don't do it. Funny. Dissector, now dissector. Actually, they have two courses. One is basic, one is advanced. The fees is very high. It's about 2.5 to 3 lakh rupees. That does not include your accommodation.
And travel.
And travel also.
That means the course costs about 8 lakhs or 7 8 lakhs.
Yes. It's very expensive. But my institute supported me inside. So I could manage by quickly.
In my time, there used to be the St. Louis course. So St. Louis anatomy course used to be there, and I think that time the fees was $5,000. And that is one of the reasons why I brought, or rather I was instrumental in bringing the dandy here, so that if you can't go there, you bring them here.
Yes.
You understand that, and I think we should do that, and you also should play a major important role in making sure that most of the people who go to Pittsburgh come to SGPGI or come to Chennai.
Yes.
And we'll charge them double the rate.
in that way, you know, Prakash has done some training in 3 months or 6 months, I think, in New York. So there are many courses running in Will Cornell, Stanford University.
Yeah, but now since we have started doing work and probably more work, I think this is the thing what we should start.
Yes.
Apollo has started its own stimulation lab here at Vanagram. So the simulation, probably these endoscopic models all should be eventually there. But I think the platforms will become virtual eventually.
Yes.
Because all these models can be easily be created, because if you see, I am not a games person, but if you see some of the thing, my son recently wasted a lot of my money and bought a Xbox. And when you see the technology there, I think we can definitely create some games for these people where they can play taking out the pituitary or, clipping the basilar from the front. So those games, actually there are peer-reviewed articles that residents who play games are better in their dexterity and decision making. Then I would definitely feel.
It does help, but I personally believe that it doesn't help much.
Okay.
I think it's better to go and watch surgery, spend some time, because that is not spending time, that is your investment. And at some high volume center, and
the problem with watching surgery, this I am talking on behalf of the students. The problem with watching surgery, even if you watch 1,000 surgeries, the actual learning happens when you are doing it yourself. And that is only possible in simulation. You can't give them it's a very catch-22 situation. That is, you should only be doing a basilar top aneurysm when you already clipped 20 of them.
Yes.
But unfortunately that is not going to happen, isn't it? So we need to develop some models of learning which can help these young men and women get over this hump.
You are very right in that way, but unfortunately models and everything, this only replica, you can't learn everything in one day. You first start doing non-functioning small tumors, then bigger tumors, then functioning tumors. Because there is gradual learning.
Because if you look at the flight models, these jet planes, unless you fly that many hours of simulation, they don't give you. I think that's a very important learning trick, that they will have to spend time both in the cadaver this thing, and they have to spend on simulation where they can really learn that very well.
Yes, you are very true. you have a dissector, little thinner dissector.
And I think we should probably have
like this, but
literally workshops on how to reduce the learning curve for every tumor and every procedure. Just a workshop on how do they, learn faster and are able to avoid complications. That's something we should put our minds together and find out ways so that they can do much better than us.
Yes. Okay.
So that is probably the ledge of bone we should have removed.
Yes.
Because I keep on telling them the initial exposure is done by the ENT surgeon, and probably from their ENT background then that much of bone removal is too much for them. So I keep goading them, but yeah, this probably either I learn it myself or I get them to do it for me. I did widen, I remember, but very clearly it was not enough. So this is one of my, what shall we say, mistakes in front of me. This should not be the thing for every neurosurgeon.
No, it happens.
Yeah.
If the exposure is not good.
And if honestly, if this young man was not so young, and if his KI index was not high, I probably would have just let him pay alone and then repeat an imaging again after 6 months and then seen, because there was no pressure on the chiasm now at all. But then because I had a problem with 2 of my earlier patients, I thought that definitely we should bring him there and get him operated now again. So the learning point here, as Professor Jaiswal told, that spend 90% of the time exposing. The 10% of the time is your tumor removal. After that, probably 1 is the tumor removal and 9 is hemostasis. So that's how probably we should classify. Especially in a patient who has had an apoplexy, probably we should take a little extra time and care for hemostasis, because even last time I remember I used flow seal also, despite my colleague Dr. Purushothaman saying that it was not necessary. I insisted and I put that because I felt it was a little oozy. One of the reasons why things are little oozy is because you have not removed the tumor completely. The bleeding stops generally when you have removed the tumor. And that is why, especially in gliomas, if you are still finding a bloody field, that means you have left a rim of tumor which is oozing. Any of the young gentlemen or ladies want to make a comment and ask Dr. Jaiswal anything?
Sir, could you please show us the landmarks?
Actually, most of the landmarks are missing. I myself is finding landmark. This is the sphenoid sinus. In front of me, I am trying to find out the midline. The best way to find the midline is, if you see, this is the bony bone. This is the bone. So that is probably the midline. In absence of navigation, you have to rely on this. So this is the bone midline, remaining part of the bomber septum. Are you able to see?
Yes, we are able to see. One of the things which I have noticed, I study the difference between the Japanese, the Indians, the Koreans. The one thing which the Americans have, or even the Europeans to some extent, but mostly the Americans, is the gift of the gap. And I think probably we should have workshops on how people can ask questions and answer questions. You should see that. He will do a small lesion and then he will talk as if he has done a doctorate in that. Because you realize that I have that feeling, you know. Even after probably 40 chapters in textbook, I still feel that the first year resident in neurosurgery talks much better than us. So I think first way to beat them is to learn that confidence. So you should ask boldly, and not only that, learn how to ask, learn how to take part in a scientific conversation, because otherwise how do you deal with them?
As Professor, so I identify the midline. This is the midline. You can see this is the remaining part of nasal septum. Okay.
Yeah.
So this is the mucosa. I am trying to find out the bony margin everywhere. First, this is the interval of the sphenoid sinus. Are you able to see?
Yeah, clear.
Okay. Mono.
It is for the students, as Professor B.R.M. used to say, the best way to learn is to follow his proverb, which says how to make the student ask questions. When they ask questions, they learn, not by reading books alone.
What's the name?
Sir, I wanted to know about two-hand technique versus the forehand. How many years or how many cases you did as a single surgeon and then converted to a forehand technique?
No, forehand means two-hand of surgeon, two-hand of assistant.
Yes, sir.
So this is always forehand technique, never two-hand technique, because your surgeon's two-hand has to be free to do my manual work like I am doing.
Yes, sir. Because in my institute, most of the surgeries that are being done for pituitary being done by a single surgeon. He holds the camera himself, and it has literally it is a one-hand technique where he is holding the camera with one hand and working with the other.
Yeah, most of the ENT surgeons does it.
Yes, sir.
They hold the camera with their one hand, and the other hand they use some instrument. But somebody holds the suction and somebody does the suction for them and then also irrigate it. So it automatically becomes forehand. It has to be forehand. It cannot be two-hand. So basically this whole bony margin is the interval of the sphenoid sinus. Okay?
Yes,
is somebody able to see it?
Yes, sir.
This R is the interval of the sphenoid sinus. I have opened it. Now I will just enlarge it a little bit. Do you have drill? पानी इस हो गया बिल कहाँ है फुट से ये कर दीजिए जरूरत नहीं है ड्रिल अल्लाह ड्रिल है यही है ड्रिल दिस इज ड्रिल No. This is stitch. No. I think drill is not corrected. ये होता है जिसमें drill और divider दोनों होते हैं. Hand with error दिखा रहा है. हाँ, hand with error है. हाँ, ठीक तो है. No.
ये आप कट दिए, आप कट। बेटा को दिखाओ, बेटा। हाँ, यस। आप कट। बैठी ध्यान सिस्टर तुम्हारे जरूरत है ना, नर्स का स्टाफ है, ब्रदर टेक्नीशियंस की जरूरत है ना, दे आर मोर जिम्मेदार और मोर मतलब दे नॉलेजेबल और डेडिकेटेड भी लगते हैं, हैं? ये नहीं कि खाने गए, नाचने खाने गए, भाग गए बिना बोले, हैं? वो क्यों हमारे यहाँ ही है? मुझे भाग गया लंच खाने पर जाते लोग सो जाते हैं, हैं? इसे बैठे सो जाते हैं।
वहाँ से तो बाद में चले ही जाते हैं।
क्या?
हमारे यहाँ चले ही जाते
बैठी बैठी करेंगे ना ये। This is the dual opening that was made earlier. Can you see? Hello?
Yes sir, yes sir.
This is, can you see this is dual opening?
Yes sir. Yes sir. Yes sir.
I'll put. Oh, dissector, patla.
ठीक है. No small assessment. There is any role of small assessment in this patient. Only role of small assessment is the MVD that I used in last case.
Please take out couch section.
Do you have curve section? Curve section is large section. नहीं होगा इसका यहाँ नहीं है, large नहीं है. तो देखो बोन का ओपनिंग यही था. दिखा ना बोन का ओपनिंग. बोन अपने कार्डियक माल. दूसरा लीजिए हमको एक बाय हाँ थैंक यू. Drill ready, please. Is Raman drill? कहाँ पे ये this is him. Okay. Thank you. I will do it. Okay, तो पैन डालेंगे. आप पकड़ लो. I will be grateful if you put some water like this. इसमें put it. Like this. Okay, or you can put like this also. Until moving part, so the moving part, उल्टा रखना है ऐसी पोजीशन रख लो. हाँ पानी. बेटा. हाँ ओके. बेटा
Just a minute. ఇప్పుడు not block. प्रांत काम करते हैं लोग नहीं, बहुत ही प्रांत काम कर रहे हैं नहीं। हमारे से ऐसा भाग जाएंगे तो मेरे बाद उनको खाने नाश्ता चाहिए होगा। क्या
यहाँ पे सीनियर हॉस्पिटल में सुबह काम कर होती हैं, केस हो गए हमारे यहाँ कभी होता नहीं, मुझे समझ
भाग जाएगा सब नहीं रुकती, ऐसी बात नहीं, इतनी सुन जाती है उनको लगा। लेकिन जो नया स्टाफ उसमें बहुत सारे लोग खराब भी हैं, तो अच्छे भी हैं, ऐसी बात नहीं है। नाथ तो भाई जैसे कोई वो देखा होता बढ़िया काम करती है।
सामने ट्यूमर है ना।
हाँ ट्यूमर है, लेकिन बोन बहुत ज़्यादा बड़ी हुई ना, बोन इतनी छोटा था ना पहले, तो बोन इतनी बढ़ाएंगे तो ट्यूमर निकलेगा एक बार से। है ना? Yes. This is the trained by technique of using drill.
Yes, sir.
This center was the previous opening.
Okay.
You can see how I will enlarge the opening now.
Yes.
वर्कशॉप का काफ़ी फायदा बहुत होता है इसलिए वर्कशॉप से इसलिए आजकल लोग वर्कशॉप वगैरह भी करते हैं कॉन्फ्रेंस कर लेते हैं जो फोकस वर्कशॉप होती है नाउ कैन रियलाइज है Actually, whatever I am doing is with anatomical landmarks, seeing the skin, everything. So in redo cases, that's why the relation is helpful.
Okay, sir.
Resector by double resector. This was the previous opening.
Okay.
You can see the body margin.
Yes, sir.
Are you able to see the body margin?
Yes, sir.
Okay, this is the body margin, this is the body margin, this is the body margin here, here.
Yes, sir.
I think over time some bone might have regrown also, might have become even more smaller.
Okay.
Funny line. Drill. You can see the tuberculum bone is very thick.
Yes, sir.
I will show the scaled bone are very thick.
What is your anterior limit, sir, of drilling?
Tuberculum.
Okay. You usually see that anterior cavernous line, those and all will be visible, usually
Because it's a case of
described in
pituitary,
textbook.
yeah, but because it's a pituitary tumor, you may not see it. It usually seen in craniopharyngioma, but let us see. Can you, I take a artery first? Yes, I am taking this. Can you focus the, somebody is here? Can you focus here? Cameraman.
the tuberculum bone is very thick. Did you see it, Prakash? You can show that this is very thick bone, tuberculum. That's why this is very thick. I have opened till here. In fact, I have gone here now. So lower limit I have got, upper limit. Camera, just can you show the camera?
Yes, sir.
Yes, just focus this area. Zoom it. Hello, can you hear me?
Yes, sir. We can see the scans.
Yeah. This is the sagittal cut of bone window. You can see here.
Yes.
You can see that this bone, tuberculum bone is very thick.
The camera can zoom in slightly more.
Yes. Okay. This bone, red white pointer is there.
Yes, sir. Yes, sir.
Is very thick.
Okay.
So I will move from here up to here.
Okay.
This part I have reached because I am bringing here. We are going inside the clavus.
The clavus.
So I have reached here.
Yes.
I am bringing this bone.
Yes, sir.
So between this window, I will take out the tumor.
Okay, sir.
Can you see? So here you can see in a better way also. You can see this bone is very thick here. Okay?
Yes, sir. Yes, sir. Yes, sir.
So I will remove from here to here so that just I will enter inside tumor.
Sure, sir.
So exposure time is 90%, you know?
Yes, sir. Even that clival recess, there's a bone.
Yeah. Actually, this tumor is in eroded the clavus, you can say.
Yes, sir.
The spread sinus is a pre-cellular type.
Yes, sir.
Dissector, patla dissector. You see here now.
Yes, sir.
This is the bone that I am talking about, tuberculum bone very thick.
Yes.
So this is the planum dura.
Yes, sir.
So I have to do this bone. This is the clavus.
Yes, sir.
This is the lower edge. You can see here.
Okay.
So I have gone here till now. This is the lower part of the bone. Tumor expression. You can see here some bleeding.
Yes, sir. Yes, sir.
And lateral. This is the lateral limit.
Yes,
this is lateral limit on this side.
Yes.
Okay. Drill.
Sir, what was used to close the previous defect? Was it an nasocircal flap?
I think there is a lot of fibrosis there. There were some maybe some RR was used or site was used. I didn't encounter the site till now.
Sir, was the other side of the septum intact, sir, during?
Sorry?
While raising the hadot flap, other side of the...
No, there is no hadot flap because there is a hole in the septum, so I cannot make hadot flap. Okay. If needed, I will use fascia, otherwise I will use fat.
Okay, thank you.
If you see the entire cellular floor, pre-cellular bone is also very thick.
Yes, sir.
पहले मतलब नहीं करता था, but I really realized वो फ्लोसी है, हाँ फ्लोसी, नहीं जलफूम बनाए हुए हैं, प्रकाश I think this is ICA. Blue जरूर है, blue दिख रहा है ना blue. हाँ एक कलर green भी कलर था, but this is कलर ICA. देखो blue area है ना?
Yes, sir. Yes, sir.
हाँ?
Yes, sir.
क्या? I don't want to bipolar. जब कर दीजिए छोटा No, but donut and gel foam. Small gel foam, just compress it. वो डबल सिस्टर है रखी दीजिए. स्मॉल कॉटन. तो वैसा कर लूँ पहले. नहीं. I put cotton first. Right. Donut. No. No, director. So I found this sometimes very useful. You can see I just put a small gel foam.
Yes, sir. And
it is stopped.
Yes.
And after some time, even if this gel foam gets removed, nothing will happen.
Okay, sir.
So if they start of bleeding occurs from cavernous sinus, so need not to panic. And then so now you can see the body opening after previous surgery. Okay?
Yes, sir.
So that's one reason it was quite small. Beautiful. until under the don't you find very unusual this type of sphenoid sinus neuralization and pituitary going down and making invitation over the clavus? Huh?
Yeah. Yes, sir.
Sorry? Yeah.
Hello?
Yes.
Yeah, I think here, now retrospectively looking, I think I got defeated by this, after here given this exposure, the thickness of the bone and the location
Yes.
was the reason.
Yes. Very true.
And once we open and we take the microscope, now when you take the microscope, we go into higher magnification and we are fooled into thinking that the opening what we made is very big. And then we have written...
No, over the time I think the opening has also become...
No, that is too short a period. I don't think so. This bone we have not removed. I know that because post-operatively the CT I was commenting to Dr. Purushothaman that the bone the opening is very small because I always get a bony window. So that has been an issue with us. So this is a learning curve for us. Definitely we had to open, but because there was apoplexy before, if you look at the first scans,
yes.
And we got apoplectic blood, and so that gave us the pseudo, confidence that we have removed the tumor significantly, because that is probably the main reason why this patient had another surgery. The anatomy of the pituitary area is very variable. Sometimes the tumor is more posterior.
Thank you.
Sometimes it is totally into the sphenoidal sinus. I have seen a total enlargement into the sphenoid sinus. So you get all varieties of these tumors.
Now don't purchase Flocil. That Flocil अवेलेबल नहीं खरीदेंगे.
Do you use the upcut at this stage when you have thinned it out so much rather than the drill?
It will come. Minute. Small. I will do it. वो यहाँ फंस गया अंदर. यूनिट है ना? Sitting there. ठीक है, उसमें अपने बढ़िया हो गया नहीं है?
हमारे यहाँ से जो भी जाएगा वो वहीं पर रोटी करेगा नहीं ये मतलब ये भी करना होगा ये भी छूट गया ना ये छूट गया दिल हाँ दिल दीजिए दिल यस यस detector double I will ask large detector okay detector हाँ up and down हाँ हमें तो फंक्शनल बहुत ज़्यादा ऊपर का खोलने की जरूरत नहीं है बट लेकिन थोड़ी माइल में खोल दूंगा ऊपर बोन का
Are you going to remove that eggshell bone also, which is there on the dura here?
Yes. I remove this bone and this small layer bone also. This way I can leave this because I am not going to here, but this part I am going to remove. You see, now the entire tumor is in front of you.
Yeah, definitely.
Oh, Baba, I understand.
Clival margin you will still drill us, sir?
Sorry?
The clival recess.
There is no clival recess here.
Okay. You will still drill because
I have drilled the lower part.
Okay.
To just release the lower margin. Well, there is no clival recess here. This nerve is pre-cellular type.
Okay, sir.
I am actually going to use this video with your permission, Dr. Jaiswal.
Yes.
Because I am now going to speak at Chandigarh in endoscopy conference on the actual learning curve of pituitary tumors. Don't you think this is a brilliant example?
Yes.
Because I am going to show the previous video of this patient, what we did, and then I will show this. I think this itself would be an adequate presentation. Do you agree?
Yes, why not?
Yeah, because that earlier thing
where we have removed, I will show that, because in the microscope it definitely looks as if you have made a big opening. But here I absolutely agree that the bony opening, and this was my concern. In fact, every time I open I ask him, can we not have a little larger bony opening? The last case which we did together in VHS, that we have got a very good resection, and there probably we did adequate. Again, the anatomy perhaps was easier there. This anatomy is a little more difficult. Again, the point to all the youngsters, keep looking at the anatomy. And then you keep storing it in your data bank. Your data bank is between your 2 ears. So that data bank must keep on having this information so that you don't make the same mistake again.
Okay.
What is the magnification of the endoscope now at this point?
कितना magnification होगा मुझे 10 times होगा? It's not zoomed.
So there is no magnification.
No magnification.
This is as it is.
I will not be 10 times. कितना time होगा प्रकाश? Normal zoom is no zoom. So now you can see entire tumor in front of you.
Sometimes in our very large dumbbell tumors, we have staged the surgery where we did the first initial part, emptied the sella, tried the valsalva. When it did not come down, we waited for about 3 months, and literally the whole tumor slides down like a slide and comes and sits in the sella, and then you remove it at the second stage. How many tumors have you done like that, Dr. Jaiswal and Dr. Prakash? In giant pituitary adenomas, how many times have you staged your tumor resection, allowing the suprasellar part to descend? We have a large number of patients whom we have done like that. What is your experience?
We actually see carefully by which approach we can remove the maximum tumor. So,
no, I am talking only about the transsphenoidal. Have you staged 2 transsphenoidals waiting for the suprasellar part to descend?
This thing goes removed. Prakash, I will say something, yes.
I am Dr. Prakash. So sir, you asked, this has happened to me 2 times where I have had residual tumor after surgery, not knowingly but unknowingly. I had thought that the tumor had descended and we had not had adequate resection. So we had taken the patient back to theatre after in one case after 2 days, and in the other case the patient, we waited for a few months, patient became symptomatic and then was re-resected. But another thing is that sometimes what happens is the tumor becomes extra-arachnoidal. It perforates the diaphragm and becomes extra-arachnoidal. In that case, then the approach will be similar to what we do in craniopharyngioma, where we will open the anterior intercavernous sinus and come into a suprasellar cistern and then dissect the tumor from the cistern directly.
Do you inject saline and try to make the suprasellar part descend down?
No sir, no, I don't.
No, not at all. Because this is a very common thing which a lot of people do.
We don't keep a lumbar drain.
Okay. But this is it's quite a dated technique. But have you ever considered it? No.
said not saline, but I have heard Dr. Ari Chapo saying that he keeps a lumbar drain and he drains a little bit of CSF to make sure that he is able to visualize all the pockets in the electrode.
They actually inject about, if I'm not wrong, 10 cc or how much? Up to 30 cc, Dr. Vasudevan says, and wait for it to descend. I have not done that. We try the Vansal valve, nothing comes down, then one or two blind this thing with the ring curate, and then we stop.
हमारा काम आसान हो सकता है, मुझे लगता है।
The cell is also very large.
No, right now.
Dr. Jaiswal, already according to us, your opening is quite large.
Yes, I'm just
smoothing it out.
Smoothing it out, yes.
All right, okay.
Okay.
Do you as a routine aspirate the dura before you make a cut? Or
No aspiration.
No, for no case?
No aspiration, yes.
Probably for the youngers.
No aspiration, no coagulation.
Okay. Probably for the youngers you must watch carefully how the carotids are placed and remember pre-operative itself decide that this is definitely not a case of kissing.
I think this is the carotid, here is the tumor. I think we can remove some part of bone here also, but it's quite okay. It's okay. Upcut. ठीक है विकास. Second knife.
Over the years, how have you grown with this? What would you tell the younger people so that they can do sing? So over the years, what you would have done a little more differently?
It is a very, I think, 10-15 minute lecture.
Okay.
I think I can tell tomorrow or during evening time.
Definitely.
It is a long journey. My practice about pituitary surgery has changed significantly. From glue to no glue, glue in every case, no glue to from no packing, lumbar drain, miltectomy.
Yeah, definitely there are so many steps.
Every step make you learn.
Yeah. This is an anti-rec.
Maybe in the finance.
Yeah. This is a hook knife which you are using.
Sickle knife.
Yeah.
Proceed.
Do we have?
I think sinus is prominent इसमें है ऊपर नीचे चलता हूँ. अपने बंद करिए ना. ये बाहर आ गया. बाहर चला गया लगता है. उसमें नहीं नहीं है ना.
again. Can you give me again? Unit. Funny. Unit. Fine. I think I will make midline cut. ब्लीडिंग बंद हो गया अपने आप ही. ऐसा तो नाइफ दीजिए, नाइफ है बस, पॉइंटेड नाइफ. No, pointed knife.
We use the 11 blade.
Yeah, yes, I am using that. Pointed knife, pointed.
There's a long needle holder actually. They'll give you that what we use for the pituitary. Ask them for the pituitary knife.
इधर साइनस था, अब नीचे कर देंगे इसे, इसको ऊपर तक घुमा ले जाएंगे. I think this do the appearing hand with this leg also. No, straight one, give me a straight one. बाहर काम करना तो मुश्किल होता है. Hold करो. Can you hold? No problem. Suction. Good.
Yeah, dural opening, there are two types you get. One is cross, where you start in the middle of the exposure, or a rectangular. So if you have issues like here, bleed, I would make it like a cross. Start in the middle of your dural exposure, extend it laterally, gradually, till you don't get a bleed or something. So
you also bring it from laterally to the midline,
yeah,
and meet in the center so that inadvertently you don't get to the carotid at all.
Yeah. So if in doubt, start in the middle, go laterally.
ऐसे कर देता हूँ ऐसे. उल्टा. उल्टा.
देखो हमने इधर से इधर किया है, नहीं तो तुम आप कंट्रोल नहीं है आपको ना. You see, my movement from lateral to medial, not medial to lateral, because in this narrow corridor a lot of turbulence and everything. If you lose if your movement is from medial to lateral, you can injure vessels, carotid and everything. Okay, particularly if they are exposed. Dissector, small dissector. Small dissector by double. Usually pituitary is very succulent tumor. Here see the tumor is very much fibrous. Biopsy. Can you have? Do you have a smaller one? Small. A smaller one? Yeah. Ultra. Very much fibrous tumor, huh? Do you give correct? Take. Here. There we are. Center. Yes, center, right. Back here, right? Center. Good, चाहिए तुम्हारा. Center. इसके ऊपर एक नोट है. क्या? हाँ, एक नोट है. Very small. Should be. Should be. Biopsy. I think where is the tumor? There is not much tumor. Huh? Dr. Pandey? Hello?
Yes, boss.
There is not much tumor actually.
The MRI shows tumor.
Yeah, but there is not much tumor.
We didn't pack so much of fascia.
Yeah, you see, there is not much tumor. This is arachnoid bulging, you can see.
You know, the first time that was mostly apoplexy, but the post-op MRI now, which is done recently, that shows tumor. So there will be tumor, I'm sure. How lateral it is the point.
What is ring correct?
Can we review the MRI also? The contrast.
Yeah. Tumor is there. I think we should not have operated this patient. Biopsy. चला के अंदर रिंग करेक्ट अंदर छोटा तुम्हारा नहीं है
More posterior is the same problem if you remove too much of tumor from the front, and so the arachnoid is descending and there is tumor behind. Will you use a soft roll to push this descending arachnoid and then try to go behind now?
Did you get ball probe? This is some amount of tumor.
Yeah. Will you push this thickened arachnoid up and then go behind it? I think there is a lot of tumor behind Aniga.
No, behind there is not much tumor, but some tumor is here. Yes. Did you see? Central. Ultra.
Sir, can we see the radiology once?
हाँ रेडियोलॉजी फोकस कर दीजिए. Can hold.
Can you put the MRI in the main PIP?
I think ये पूरा बोन ये है ना. सीजर 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 माइक्रो नो ये दूसरा सीजर होता है ना एक फिक्स्ड टाइप.
Can you put the main MRI on the main PIP, please?
You don't have those seizures. Oh, no. Seizure like this. आगे seizure होता है उसका like this. ऐसा है आगे आपके पास. हाँ endoscopic. Yes. इधर थोड़ा ट्यूमर लगा हुआ है. वो अंदर तरफ है. इधर थोड़ा बोन मटेरियल करें तब आएगा. क्यों कर रहा हूँ देखता हूँ. लाइकोएडो एंगल सेक्शन है इनके पास. देख पा रहे हैं इनके पास नहीं. बहुत ही yes. Can you hold? Just ring it. देखा.
The axials, are there any axials there? Let us see if it's lateralized to any one side.
Axial scans.
Actually, when you compare this to the earlier one, it seems to have descended, and obviously the apoplectic part has all come down. So the solid part of the tumor has also descended down.
अच्छा रिवर्स रिटर्न नहीं दीजिए. वो सिग्नल नाइफ.
Actually, Dr. Purushothaman does not believe because he didn't see a CSF leak. So at my insistence, we have put the fascia and fat. So probably
this part is the, I think, the retractable part.
Yeah, so that's what is worrying you now. We can really give trouble to people.
Bulb.
Dr. Jaiswal, is this behind this anterior veil? Is there any posterior tumor?
You see, no, I don't think. You see,
yeah, behind
continue from here to here.
this idea normal grind maybe compressed. Can you see?
Yeah, but can we
you can see, no. If you see,
yeah,
just go behind.
In the middle.
Okay, no, nothing much.
Okay.
Nothing much. You go, see, nothing much. One half काफी लग रहा है यार. तुम थक गए हो.
This another issue is there in these redo pituitaries can be actually a workshop on their own, because a lot of time when we have gone back, we have not been able to remove anything significant. Do you agree, Dr. That is the redo times, many times when we have just gone and we have not been able to remove, because I think the fibrosis and so many other adhesions.
There is lot of fibrosis and some tumor is there which I am going to remove and will affect.
Okay.
Proceed.
But the problem is, if you send this to the radiation oncologist, he will tell us to send her back and have some more tumor removed, then only I will give radiation. So that is a common issue with
पानी. Battery.
For many years, with the exception of neurosurgeons at VHS, that is Dr. Ravi, Dr. Vasudevan, many of the Apollo pituitaries were being referred directly to Dr. Ayappa. Dr. Ayappa is a senior ENT skull-based surgeon and whose expertise is pituitary tumors. So obviously, though the neurosurgeon used to be present, Dr. Ayappa, as another of my colleagues, Dr. Giridharan just now said, that they would do it with one hand and one hand dissection. And that pituitary way of, ENT way of removing the pituitary is quite different. But obviously it requires that, a lot of neurosurgeons at that time who were not doing this on their own. But Dr. Ghosh always was doing his things, and only very rarely would he require Dr. Ayappa to come and help out in case of a distorted anatomy. But I think that also now you will require navigation, and navigation takes you a great way there. That's a tumor shell.
There is, I think some tumor is there.
Yeah, there is a tumor shell there coming from that side.
Okay. Repeat.
As you saw, he is trying to be very, very careful to avoid an arachnoidal breach, because once that arachnoid breaches, then the chance of him getting a CSF issue is also. Even now we may not know, there may be somewhere from where the...
Is it fat or something? I don't know.
Unfortunately, the immediate post-operative, there was a hematoma, so we really can't tell you that. But definitely at my this insistence, fat and fascia has been placed.
I think
because he is very reluctant, he doesn't like to put, but I don't like to take a chance actually. These redo surgeries are a big no-no for me. That I think is posterior tumor behind your arachnoid.
Yeah, some amount is coming.
Yes. That is definitely arachnoid, isn't it?
Arachnoid.
Yeah, so this is what traditionally happens if you have to remove too much of tumor from the front. So that arachnoid is now creating a lot of problem for us and coming in front. That's arachnoid, no doubt. You want a soft roll on that to protect it and push it up and then take it out from behind?
It will come in my way.
Okay.
डिसेक्टर दीजिए तो बाई वाला डबल
What is adherent there is not tumor, perhaps that is what we kept last time. Because that is stuck to the arachnoid, thickened arachnoid, yeah.
ज़्यादा नहीं है. I think this is also some part of tumor. नीचे है ना? मतलब इसके ये इस पे जेनल रखा है, तो चिपका हुआ था. दिखा सकता है. एक बार ये.
Once in AIMS All India Institute workshop, they had given Dr. Anil Nanda an ophthalmic artery aneurysm, but it was already wrapped and already approached, and I thought that was a very wrong thing to do. So today perhaps again this is not the ideal case we should have given Dr. Jaiswal.
No, but you see, this part has got clear, but I think the lower part, this part which I am separating has your reconstruct part.
Yes, definitely.
I think this has some fascia piece in there.
Yeah.
Let's see. I think
that's a fat, isn't it?
I'm not sure. This is your fat or tumor. Battery stuck.
That's arachnoid.
That is arachnoid, yeah. तो बैटरी थोड़ा मोटा बैटरी बड़ा उससे बड़ा हाँ. I am not sure this is reconstruction part.
I think that is the reconstruction part most probably. On laterally when you got, that was tumor.
there was some tumor.
Yeah, that was definitely tumor. Try on this side also, on this opposite side, on the left side, and see if you get, and then you can take a call.
This I think is tumor, some part.
Okay, behind, posteriorly.
Yeah.
Okay. No, I think that is his reconstruction.
Maybe.
Nothing behind there, no?
No. Okay, no. No. Now give me another section. Dissector. Under center. Hello, thank you. You see, this is continue.
Yeah.
This is continuing.
Yes.
Intersection. Can give me intersection. Section, yeah. Half an hour.
Dr. Prakash, any ideas?
I think this side is also clear.
Okay. Yeah, now you are going posterior to that descended curtain. Yeah.
So this finishes the procedure, I think.
Okay.
Slightly. So there is no leak, so I will put some fat.
Okay.
Can fat.
Will you do a Valsalva now?
You can do it. Fine. Donut.
My impression towards the end of the surgery, when I thought I had a reasonable tumor resection, and
yes,
actually you're not having any significant oozing also now. So
can you do that slow now? Okay, there is some amount of bleeding, otherwise nothing. It's venous bleeding because of ulcer.
Yeah.
Okay, thank you. Fat, is it fat? No, fat. Fat and then stump size gel foam. No, stump size, it's like this. This is what I think I fat. Got it? Please count. Resector. Hello?
Yeah, we are with you. We are watching the fat.
Yes, so because there is no CSF leak, so I will just put a fat here. Oh. चलो ठीक, thank you प्रकाश.
The arachnoid. The arachnoid is pushing it out, I think.
Yeah. Well, doesn't matter. Because there is no leak, so I am not much worried about this. Okay.
You want to stick it in place with some surgery wool or something like that?
Yeah, I will put some gel foam. Eventually it will. Sorry? Thank you. It has to be.
I think that should be fine.
Yeah. No, it's this size. First split it. तुम भी थक जाते हो यार. Actually, दूसरी का सेक्शन देखो सुधर तब कितना टफ सेक्शन है. Yeah, keep on. This size. फिर भी ये दूसरा तो बढ़िया ही है. अगर दूसरे का तो नो पता नहीं. नहीं गलत. मुझे लगता है कि जो बेचारा डॉक्टर पैसे चेक कर दिया गया यहाँ पर. अभी तुम्हारा पेशेंट पैसे चक्कर में आ गया ना आया होता तो शायद हम उसका हमारा अपने इसको करते बढ़िया से नहीं. क्या बहुत ही गंदा था. उसमें पहली बार तो ट्यूमर के बीच में अभी नहीं पता चल पा रहा था हमें. इसकी वजह से कलर्स की वजह से. कलर देखते हैं वो बेसिकली ना कैलिवर करने के लिए था. डेमो पीस आता है ना कि देखोगे आप जो है ना मैं देखा हूँ कैलिवर डेमो पीस था.
तो अपने इसको री कर लेंगे वहाँ पे
जो अभी कर रहे नहीं करेंगे बाईपास किया जाएगा देख लेंगे पैसे निकल देंगे देखो उसका मेन बात ये है कि विजन ठीक है अभी फिलहाल और दूसरा कि केवल संजमा है ईएस से पढ़ता है करता है देख लेंगे उसको लेकिन बाद में एंडोज नहीं कर पाएंगे अब उसको करना होगा ना ट्रांसपैल्पेबल करेंगे So it's looking okay?
Yeah, perfect. Thank you.
Okay, thanks everybody.
Congratulations on a good job. Thank you so much. Yeah. It's a difficult job.
Brother. So now I will deposit this inflatable in its place. And there is no packing. Because nose is absolutely clean. No.
So you will not even put that narrow cell or something like that?
No, it's not required. You see,
Okay.
the nose is absolutely clean. No bleeding.
No, just to keep the this gel foam in place? No.
No, gel foam will be in place.
Okay.
After some time, 70 to 24 hours, there will be some epithelialization. It will not come out, you see?
Okay.
It is in place. This side wall is also very clean. No bleeding. Okay.
Yeah.
No bleeding, no packing. Packing causes a discomfort.
If you keep a mirror cell, even slight oozing will be absorbed by it, so patient won't be anxious when the droplet of blood comes out. And tomorrow morning we can pull out the mirror seal.
Yes, we can do it, but I think not much bleeding. No oozing, nothing.
It's not for the bleeding, but slight oozing is expected.
Yes. मेडिसिन लाते हैं मेडिसिन है हमारे पास ले लो भाई तो पैसे में छोड़ी है So I am putting some narrow cell which will be removed tomorrow, okay? हाँ तो मेरे से मेरे से बोल काट दीजिएगा Only disadvantage medicine, it may take out your fat also. So there. So good. तो कौन डाल देंगे? We put
I take this opportunity to thank all the faculty for having, taken the time off from your busy schedules and to come and do this very difficult teaching program. It's not easy, and from what feedback I am getting, a lot of people at least have watched it online, and I am planning to keep it on the YouTube for people who can probably send links to this, and so that it can be really watched and the learning can continue for quite some time. Thank you. Thank you very much.
Thank you very much, sir. I am really honored to be a part of here, this event. And actually, let me tell you that I saw today the museum here, and I think this is the history of neurosciences in India. And it is indeed, I think everybody working here should be very proud of Professor B.Ramamurthi, who has done wonderful job in creating this department, and he has left a great legacy here. And I think the association with SCPGI will keep on continuing. On behalf of all our faculty, I congratulate all the organizing committee and the team for this wonderful workshop. Giving cases is a huge task. Thank you, Dr. Krishna, Dr. Vasudev, Dr. Anil Pandey.
Thank you everybody. Thank you so much. And we are looking forward to having you all with us today in the dinner. So please do come. And tomorrow obviously is a big academic feast with the oration with Professor Ganapati giving his talk. The oration is named after the father-in-law of Professor Ramamurthi, Dr. Achanta Lakshmipati, a great doctor, an ophthalmologist, a philanthropist, and his memory we cherish because he is the one who has supported the department for a long time in his inception with funds and with encouragement, and he is a remarkable person on his own right, and that I will tell you all tomorrow. So looking forward to a dinner and meeting you again. Thank you everybody.